And we are live in 30 seconds, sir.
Yeah. Okay. Some mic is still on. Yeah.
Sir, we are live now. Good to go, sir.
Yeah. Fine.
Hello.
So, good morning, Jimmy.
Good morning. Good morning. Good morning.
We just starting. Yeah.
Jimmy,
Hello, sir.
Mute yourself and switch off your video.
Okay. Okay.
Yeah. So, good morning, everyone, and let me welcome you all to this edition of the Continuum. It also, I think, is the last academic program this year within our group. There could be one or two others coming up. So let me welcome all of you. And as you know, we sort of do these 6 in a year under the chairmanship of Professor Katrak, and I've joined him for the last 3 or 4 years. So this time we will do it in this way. There are 30 minutes for each speaker. There are 5 speakers. So if the speakers could please finish in 20 minutes time, and then there could be a discussion from the faculty members. Whatever questions you have, you type them, and we will try and answer them. And then we have a little backup time in the end. So first presenter today is Dr. Parthvi, and she's going to talk on coma and brain death. So Parthvi, you want to start?
Yes, sir. Okay. I'll start. Sir, am I visible? My screen?
Yes. Yes.
Okay.
You are visible and audible.
Okay. Good morning, everyone. Today I'll be talking about coma and brain death. First of all, starting with the definition of coma, it is a state of unresponsiveness in which the patient is not awake and cannot interact with the environment even after vigorous alerting stimulation. This is a very basic spectrum of consciousness, starting with alertness, then goes to drowsy or confused when patient responds to verbal stimuli, then goes to stuporous when he responds only to painful stimuli, thereafter which comes a state of coma. This is the diagram, again the whole spectrum, starting with consciousness and awake state, going to drowsiness, light sleep, and finally coming to coma. First of all, we need to know what the alert state requires brain-wise. So the reticular activating system has an arousal mechanism. It is basically a network of neurons interconnecting between brainstem and posterior diencephalon. When this is disrupted, consciousness is disrupted. Also, the thalamic nuclei, they exert tonic influence on the activity of entire cerebral cortex, and relay between the RAS and the thalamic and cortical areas is accomplished by neurotransmitters. So any problem in either the RAS, the thalamic nuclei, or the neurotransmitters can cause change in the alert state. Consciousness is best conceptualized as having 2 domains. One is the level and the other is the content. Level refers to the degree of arousal, that is, the patient is fully awake or does he require stimulation to awaken and respond. And the other thing is content. It refers to the degree of awareness, that is, the patient coherent or is he attentive, confused. So to affect this consciousness, the lesions of the cerebral cortex must involve both hemispheres or must be unilateral lesions large enough to cause displacement of midline structures. If there is brainstem or diencephalic lesions, they might be small, but then they may also involve bilateral structures. The proximity of reticular activating system to midbrain structures that control the pupillary function and eye movements permits clinical localization of the cause of coma in many cases. So causation is classified anatomically as well as each etiology wise. So anatomically, it includes hemispheric brain lesion with tissue shift and herniation, diffuse bilateral hemispheric damage, bilateral diencephalic lesions of any sort, cerebellar lesions causing brainstem compression, and intrinsic brainstem lesion, and hydrocephalus. Similar goes for the common causes of coma, which we all are very well aware of. We will see what is the approach to clinical approach to coma, including 3 main things: physical, general, and neurological examination. Physical examination includes the basics: airway, breathing, circulation, after which we see the temperature, and fever, we, as we know, can have etiology as sepsis or any CNS infection, whereas hypothermia may be due to intoxication, alcohol intoxication, barbiturate intoxication, drowning, and exposure to cold, or peripheral circulatory failure like of any kind, and infections again like advanced TBM or then mixed edema. Dyspnea and cyanosis, if the patient is showing, they can be reversed by correction of hypercapnia, which might be the cause of it. In general examination, the most important thing is to watch for a petechial skin rash, which might suggest the possibility of meningitis. In neurological examination at the bedside, you have to check for these 6 main points: degree of unresponsiveness, brainstem reflexes, position of the eyes, muscle tone, focal or lateralizing signs, meningeal signs, and any other movements of the eyes and limbs. For example, if it's a seizure or any kind of hysterexis or myoclonic jerks, we can differentiate it at the bedside. Two main scores are developed for degree of unresponsiveness. First is the Glasgow coma scale, which we all are aware about. What we don't know about the Glasgow coma scale is that once intubated, it loses one of its 3 components. 5 points out of 15 are out once the patient is intubated. Left with the other 10 points, which is also skewed towards the motor response because motor has 6 points. Now, it also does not incorporate breathing pattern and brainstem reflexes, which are again very important in a coma patient. So they developed a new score called the 4 score, full outline of unresponsiveness score, developed by Which Dix and colleagues. It has 4 components, including eye, motor, brainstem, and respiration. We might be using this in the ICU, so I won't go into the details. Just that 0 to 4, it is a scale of 0 to 4 for each and every modality, and 0 being that of a almost dead patient, being no response, and 4 being that of a fully awake patient, including 4 being pupil and corneal reflexes present, or respiration, regular breathing pattern, and so on. So after the degree of unresponsiveness is known, we see the pupils. Grossly, pupillary enlargement with loss of light reaction and loss of vertical and adduction movements of the eyes localizes to an upper brainstem lesion. Whereas if both of these are preserved, then widespread structural lesions or metabolic suppression of cerebral hemispheres is suspected. So this is a pictorial representation of different pupillary signs which can be seen in different lesions. For example, in a metabolic or a diencephalic problem, we will have small reactive pupils. If the lesion is in the midbrain tectum, they will be mid position, unreactive, and sometimes might have a spontaneous hippus. In midbrain tegmentum lesions, they might be mid position, they might be irregular, unreactive, and non-centered. If the peripheral fascicular or peripheral nerve problems are there of the cranial nerves, then the problem will be large or unresponsive ipsilateral pupils, that is unequal, and pontine lesions will have pinpoint pupils, which will still be reactive to light. As a rule, always, coma is due to bilateral hemispherical disease when these brainstem activities are preserved, particularly pupillary reactions and eye movements. However, the presence of abnormal brainstem signs does not always indicate that the primary lesion is in the brainstem, because hemispherical masses can also cause secondary brainstem pathology by transtentorial herniation. This is the decorticate and decerebrate poster, which helps us to localize the level of the lesion. Decortication is bilateral damage rostral to the midbrain, and decerebration is damage to motor tracts in the midbrain or caudal diencephalon. Now, that was at the bedside clinical and neurological examination. Then when we go to the investigations, besides having the usual blood tests and imaging and lumbar punctures, what is important is the EEG, which has been a topic of debate. So the value of EEG in patients who are comatose is generally very less clear. The EEG is always abnormal in patients who are comatose, but is far less commonly used for reaching a specific diagnosis or assisting in management. Definitely indicated in patients who fail to awaken after a prolonged clinical seizure or multiple clinical seizures, and when ongoing subtle clinical manifestations of seizure are suspected. These abnormalities may just be the manifestations of a brain disorder that is causing the comatose state, in which case initiating treatment to correct them would be futile, if not detrimental. Until more definitive information is acquired, it is advisable to be conservative with the interpretation of the EEG abnormalities in patients who are comatose. So after diagnosis, when we come to management, and if we still don't know the etiology, we have to think of the treatable causes first, most probable treatable causes. Starting with basilar artery occlusions, status epilepticus. These are the most common treatable causes which we see day in and day out. Fulminant bacterial meningitis, severe herpes simplex virus encephalitis, hydrocephalus, venous sinus thrombosis, some intoxications, and brain herniations from an excisable mass or collection, or residual effects of sedative drugs in patients who are critically ill with impaired clearance. They may result in misguided prognosis and premature withdrawal of life-sustaining measures. The management of coma includes acute management, symptomatic, and intensive care. Acute management is maintaining ventilation, oxygenation, maintaining sufficient blood pressure for organ perfusion. And the main three principles which I found important to mention is these three principles, that any cases of hypoglycemia, we should remember always to give thiamine before dextrose. If we are managing a patient of benzodiazepine poisoning or overdose, always we must remember that if we administer flumazenil to reverse it, it may be complicated with seizures, and then we don't need to administer anti-epileptic in such cases. And also that we must be aware that the effects of naloxone, which are used to reverse the opiate poisoning, as well as flumazenil above, are transient. Regarding therapeutic hypothermia, the targeted temperature management to 33 to 36 degrees Celsius have been found equivalent in a solid randomized control trial to provide neuroprotection, followed by strict avoidance of fever. And this should be a part of standard care of patients who remain comatose after CPR. One must avoid infections, especially ventilator-associated pneumonia, urinary tract infections, as well as venous catheter-related infections, and venous thromboembolism from immobility, skin breakdown, eye injury from exposure, malnutrition. These are the issues which need to be tackled in intensive care. There is what's new in managing patients of coma. There is neurostimulation to improve alertness is a subject of debate. In a randomized controlled trial, amantadine was shown to accelerate the recovery of consciousness after traumatic brain injury, but without improving overall outcomes upon further follow-up. Other medications such as zolpidem, fluoxetine, methylphenidate, and dopaminergic agents are only supported by few anecdotal reports, and even the value of DBS is unproven. So that is very, and regarding the prognosis of coma, depends on its cause and duration. Rapidly reversible causes, even if initially severe, can have excellent prognosis if patients have no substantial residual brain injury. In general terms, it is true that longer the duration of coma, lower the chances of regaining consciousness. A discussion with family is very important regarding the optimal level of care for each patient and should always incorporate any previously expressed patient's wishes, or alternatively the most likely patient preference in such a situation as understood by the family. Now, after coma, there is a thing called prolonged disorders of consciousness, defined as any comatose state lasting longer than 28 days. It might be a result of widespread brain damage, developing substantial brain atrophy over time. Vegetative, there is two main definitions: vegetative state or unresponsive wakefulness syndrome. So that is when spontaneous eye-opening and sleep-wake cycles without any purposeful behavior suggestive of awareness of self or the environment are ongoing. That is a vegetative state. And then there is a minimally conscious state. That is when such purposeful behavior becomes apparent, the patient has recovered consciousness. If the patient continues to have severe alteration of consciousness but exhibits purposeful behavior even briefly or inconsistently, the patient is said to be in a minimally conscious state. This minimally conscious state is further divided into two subtypes: minimally conscious state plus, which is when the patient regains language function, and minimally conscious state minus, that is when the signs of conscious awareness do not include language. It might include visual tracking, object manipulation, affective reactions to external stimuli, but it does not include language. Emergence from a minimally conscious state is characterized by recovery of functional communication or functional use of objects, as this both subtypes are there. Now, good outcome after delayed recovery of consciousness is also seen in a lot of patients, that is even after prolonged loss of consciousness. Especially in these four cases, that is young patients with drug intoxications, prolonged refractory status epilepticus, autoimmune encephalitis, and severe traumatic brain injury in young patients. At the bedside, for regular monitoring and prognosis, we use the Coma Recovery Scale Revised, which is a very good tool, standardized neuro behavioral assessment tool. And functional MRI as well as FDG PET can show us the changes in brain metabolism, thereby helping us prognosticate it. So I'll come back to this slide later on. Now that was about coma. Now we'll go to brain death and just see very shortly what exactly is brain death in our country. So the definition that is accepted globally is death determined by neurologic criteria. It refers to a condition in which systemic circulation is preserved but no evidence of any brain or brainstem function is present. The diagnosis does not permit ambiguity and the implications are final, and therefore the diagnosis must be definite and unquestionable. India follows the UK concept of brainstem death. So in 1994, the Transplantation of Human Organs Act (THO) was passed by the Indian Parliament, which legalized brainstem death. In 1995, these rules were laid down to describe the brain death certification procedure. Despite this, the brain death is not promptly declared in India due to lack of awareness and doubts regarding the legal procedure of certifying brain death. Section 46 of IPC states that the word death denotes death of a human being unless the contrary appears from context. So this question comes in, especially in cases of resuscitation and organ donation. Now, why we must define brain death? First of all, to avoid prolonged futile life support and to promote death with dignity. Who will certify the brain death? Team of 4 medical experts, including medical administrator in charge of the hospital, authorized specialist, authorized neurologist or neurosurgeon, and medical officer who is treating the patient. Now we come to the criteria that is required before stamping it. So one examination is sufficient in most countries, including India, to declare brain death in adults. But in pediatric cases, a second examination is required. And if the patient is between 37 weeks to 1 month, then 2 examinations should be separated by 24 hours. If the patient is between 1 month and 18 years, then the 2 examinations should be separated by 12 hours. So in adults, 1 examination, in pediatrics, 2 examinations. The criteria for brain death. This is a bit busy slide, but it includes the entire criteria that the patient should be deeply comatose due to irreversible brain damage of known etiology, and we must exclude the reversible causes of coma. Patient should be on a ventilator because of the cessation of spontaneous respiration. We must exclude neuromuscular blocking agents such as a cause of respiratory failure. And most importantly, all the brainstem reflexes should be absent. Pupillary light reflex, doll's eye head movements, which can be tested by the caloric test, corneal reflex, no motor response to stimulation within any cranial nerve distribution. There should be no gag reflex, no cuff reflex, no vestibular ocular reflex, and the apnea test. This is the oculocephalic reflex, which we test in awake patients at the bedside, and we can take help of the caloric test to test that. All the prescribed tests are required to be repeated after a minimum interval of 6 hours because to ensure that there has been no observer error and persistence of the clinical state can be documented. The diagnosis is based only on the clinical examination. It is not required legally or for diagnosis that we have a neurophysiological study or any imaging study done. And confirmatory tests may, however, be carried out if a panel of doctors is in doubt or disagreement of the diagnosis. So this is the brain death algorithm given in Continuum, that if an irreversible coma from a known cause is found and we exclude the confounding factors and there is absent motor response to pain and all brainstem reflexes, then we go for an apnea test. I will just discuss the apnea test, but if on apnea test there is no spontaneous breathing, then we can stamp it as brain death, first thing. If there is presence of spontaneous breathing, we must repeat apnea test after an interval since these factors are present, and then see if there is no spontaneous breathing, or still if there is a doubt, then we must go for ancillary tests. Which are the ancillary tests? I'll just discuss that also, and we can confirm brain death over there and then repeat it after an interval if necessary, hence stamping the patient as brain dead. So as a prerequisite for brain death, we must, as I already said, establish an irreversible cause of coma and confirm the absence of confounding factors. What are the confounding factors? So prescription and recreational drugs that can depress brain function, pharmacologic neuromuscular blocking effect, hypothermia, hypotension, major metabolic derangements, may it be electrolytes, acid base, or endocrine. Then we must confirm coma as per the definition. That is, no evidence of responsiveness to any stimulation in the form of either eye opening or eye movement or any motor response, which most importantly cannot be explained by the spinal reflexes. As I just discussed about, confirm the absence of brainstem reflexes, that is pupillary reflex, corneal, oculocephalic, gag, cough. And then we must confirm the apnea. So complete absence of breathing drive despite high PaCO2, which stimulates the medulla oblongata respiratory center, should be established by a formal apnea test. Ensuring steady delivery of oxygen and having immediate access to vasopressors are essential conditions for successful completion of the test. And in rare instances, the test must be aborted because of hypotension or hypoxemia. It is reasonable to consider a new attempt after adequate preparation. Now, what is an apnea test? So, four things must be done before starting an apnea test in the ICU. PaCO2 on the ABG must be 35 to 45. Systolic blood pressure must be above 100 with or without vasopressors, because if the patient is hypoperfused and with low BP, there is no point of doing an apnea test. Administer 100% oxygen for at least 10 minutes. That is ideally PaO2 of 200 mmHg with positive PEEP of less than 5, and absence of clinical sign of intravascular volume contraction. Steps for the apnea test are to disconnect the patient from the ventilator and then delivering oxygen at 6 liters per minute through a catheter into the endotracheal tube. Look carefully for any respiratory movements while monitoring SpO2 and blood pressure, and abort and reconnect to the ventilator if evidence of respiratory movements, refractory hypotension, that is systolic BP of less than 90 is found, or worsening hypoxemia, that is SpO2 of less than 85 is found. If no respiratory movements are present after approximately 8 minutes, obtain a ABG, which will show PCO2 retention. They can complement the ancillary tests in cases of a dicey apnea test. They can complement the neurological examination but should never replace it. Their most appropriate role is when certain aspects of the neurological examination cannot be performed, like when an apnea test cannot be safely completed in a patient with severe pulmonary contusions, acute respiratory distress syndrome. The ancillary tests include EEG, nuclear medicine scan, Doppler, catheter angiography, and a CT angiography. So the EEG, as we already discussed, that when it will be helpful in cases of brain death is when there is complete absence of cerebral electrical activity, including lack of reactivity to intense, painful visual stimulus and auditory stimulus.
I think you'll probably need to close shortly.
Okay, sir.
Yeah.
And so the nuclear medicine scan, transcranial Doppler, and a catheter angiography, CT angiography, which will show that there is absence of flow in the distal MCA territory arteries. And so the last thing is regarding reversibility. That is, 15 years after its first report, American Academy of Neurology issued an evidence-based guideline update in 2010. And this concluded that there is no published reports of recovery of neurologic function after a diagnosis of brain death using this criteria. That is the algorithm that we showed of using the ruling out all the confounding factors as well as cause of coma, and then doing the apnea test. There is a positive evidence to determine the minimally acceptable observation period and reliability of newer ancillary tests. Apneic oxygenation diffusion to determine apnea is safe.
Parthiv, you must conclude, please.
Yes, sir. So some reports appeared in 2008.
I want to make some remarks, please.
Yeah, sir. So that's it, sir. Reversibility. This criteria fared well according to the study published in 2010. Okay. Thank you, sir.
Great.
Can I make some remarks?
Yes, sir. Please, we request you to.
Yeah, fine.
Yeah.
As you mentioned, that consciousness depends on two aspects: arousal from the reticular activating system and the content of consciousness, which is a function of the bilateral hemispheres.
Right, sir.
Therefore, when you're faced with a patient with an impaired level of consciousness, you should always ask yourself three questions. Is the patient awake and aware, which is the normal situation, except in a locked-in state where the patient is awake and aware but cannot move any of his limbs? Okay. The second is where the patient is awake but not aware. That is acute confusional state, akinetic mutism, etc. And lastly, the patient is not awake and not aware. All right?
Okay.
The second point, as you made a passing mention of localizing and lateralizing signs, but you did not elaborate on that. I would like to just tell you a few points on that count, you know. Secondly, before I go on to that, I would like to talk on brainstem depression because of drugs. Now, when you suspect there is brainstem depression because of drugs, because in a comatose patient, sometimes the history is not available. And therefore, you have to look at certain features on examination. And that those features are that if the pupillary and corneal reflexes are preserved out of proportion to the horizontal oculocephalic maneuver or oculovestibular reflexes. Because those brainstem reflexes are entirely suppressed by brainstem depressant, whereas the pupillary reflex and the corneal reflexes are slightly resistant to that. And if you suspect it, then you can do a confirmatory test in which a unilateral ice-cold water caloric will produce an upward gaze palsy because the MLF has been cut out. Whereas upward gaze palsy is above the tegmental and above the tectal area, and therefore that is preserved. Okay? So that is the second point that I'd like to make. The third point is that your system of examination must be a little systematic in the sense that the first thing that you must observe is position, posture, and spontaneous movements of the patient. Then you can observe the respiratory pattern, but that is nowadays superfluous because at the drop of a hat, the intensivists intubate the patient and put them on a ventilator. Okay? You must rule out fractures of the skull or the spine before you check for neck stiffness. Or you try and do the oculocephalic maneuver. All right? Then you must do a fundal examination, and then you go to levels of consciousness with signs of lateralization, brainstem activity, etc. And talking about lateralizing or motor signs, I like to stress on certain observations that you can make at the bedside. For example, a weakness or a grasp reflex or focal seizures will give you focal lateralizing signs. Okay? If a patient is plucking or clutching at his clothes, he has intact corticospinal tracts. All right? If the patient grimaces to deep painful stimuli, okay, supraorbital deep painful stimuli, he has intact corticobulbar tract signs up to the pons because it comes through the facial nucleus, grimacing. And grimacing is a voluntary thing. So if a patient grimaces, even the prognosis is better. All right? Then if a patient has roving eye movements, the pons and midbrain are intact because you require the median longitudinal fasciculus for that. All right? And if you have multifocal myoclonus, it means hypoxic ischemic or metabolic encephalopathy. So these observations are very simple at the bedside and they give you a lot of information. And the last point that I'd like to make, that all the pitfalls in the diagnosis of brain death are usually because people have not established the cause of the coma unequivocally. All those cases, if you go and see all the cases where patients were diagnosed as brain death and then suddenly woke up, in the past, it is because the cause of the coma was never established. And in 2013, I took CNS infections due to solid organ and stem cell transplantation. And in those cases, the cause was established as encephalitis, but encephalitis of unknown etiology. And cases of rabies were missed. So that is because the cause was never established unequivocally. And lastly, I'd just like to say that Azad Irani will give you the reference that in neurology recently, I think in May, Azad?
Yes, sir, correct. Me.
In May issue of Neurology, American Academy, there is a complete consensus articles on trying to encapsulate all the criteria for brain death. And that is a further on the 2010 criteria that you have mentioned. So those are the only comments that I'd like to make.
Yeah, I think fantastic. I think you've given such simple bedside things. I think this topic is very important, so we can borrow 5 minutes from our last half an hour. So we have 3 more minutes. Any comments from Dr. Lalkaka or Dr. Shirsat? There is one question that has come from the floor. Do you recommend caloric test with VNG as a documentary video evidence of no response? Dr. Vinod has asked this. So Parthvi, you want to answer that question?
VNG wasn't mentioned as a requirement in any of the references that I saw, sir. Means cold caloric test is.
Arthi, can we have your video, please?
Yes, sir.
I'd like to put a face to the voice.
Correct. She's absolutely correct. Yeah.
So the VNG wasn't mentioned in any of the references that I found, but for documentation we might do it. Cold caloric test is obviously. I read about it, sir, that it has to be done.
But as transplant programs become more aggressive, this is going to come. Because,
Yes.
Because the transplantologists are extremely aggressive. I mean, it is ridiculous. Any hospital which is on the panel who has a potential brain organ donor, each and every transplant physician knows about it. It's terrible. So we will have to keep ourselves in a very safe position to get this done. And secondly, I want to re-emphasize what Dr. Katrak said. Unless you are satisfied of the diagnosis of the brain stem death, do not certify brain death. Please, please, please.
As long as
apart from rabies, think of snake and envenomation. We can have dilated pupil, and we can have complete paralysis of the limbs. There's some forms of Guillain-Barré that have confused people. Botulinum have confused people. So be very, 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 very careful about diagnosing brainstem death unless you think of yourself as a neurologist. Don't think of yourself as a brain death certifying person. Think of a neurologist. You get convinced about the diagnosis, and only then you certify brainstem death. That's the way to go about it.
To answer that question about cold calorics is more sensitive for horizontal gaze than oculocephalic maneuver. And you should do it if you are suspecting a brainstem depression due to drugs.
Yeah.
You know, otherwise, I think it is a slightly neglected mode of examination in a comatose patients.
Yeah.
Because there are certain prognostic indications also. If you get nystagmus when you're doing a cold caloric, it means that it's a very good prognosis. The patient will recover. Because the saccadic component, which is responsible, you know, takes its origin from the PPRF. That means the pons has to be intact. And the MLF has to be intact. right from the pons to the midbrain.
Yeah.
So it has certain implications also, prognostic
Correct.
implications also. Okay.
Yeah. I think we'll probably come back to this topic if time permits later on. So maybe we can go on to the second topic. And before we ask Sumit Kharat to talk on subarachnoid hemorrhage, by the time he puts his slides up, Azad, you want to tell about the Google Forms? We have just now got 36 participants from Bombay and Pune and 11 faculty members. So, which is good. And Rahul and Faiz have sent their students. Faiz is on leave and I don't see Rahul yet, but his photo is on the by mistake. Rahul and Faiz are not in the they have the participant links, no? Rahul Shah or Chinmay?
Sir, I'll just check and tell, sir.
If they are there, please move them.
Yes, sir.
Right. So Sumit, welcome and tell us within 20 minutes about subarachnoid hemorrhage.
And will you please keep your video on so that we will shut off all our videos, but
it becomes easier. Yes.
Sir, my video is on, sir.
Yeah, we can see it. You keep it on. Yeah.
Yes, sir. Thank you, sir. Good morning, respected teachers.
Very frankly, I know what you look like, but the others should also know.
Yes. So I will be talking about subarachnoid hemorrhage. I will talk mainly about the.
Your voice is a little soft.
Sir, I will. Is it okay now, sir?
Little better.
Sir, I will be talking about non-traumatic subarachnoid hemorrhage. It is a type of hemorrhagic stroke and a neurologic emergency with substantial morbidity and mortality. Most commonly, it is due to rupture of saccular aneurysm and comprises 3% of all stroke types. And it has very high mortality. Pre-hospital and mortality is 15% and 30-day mortality is 35%. It has annual incidence of 6 lakh cases worldwide, and it can cause permanent disability, cognitive deficits, and mental health symptoms. So causes of subarachnoid hemorrhage are most commonly it is due to ruptured cerebral aneurysm, arteriovenous malformation, arteriovenous fistula. RCVS can also cause the same, and in cortical area it can be due to rarely due to cerebral amyloid angiopathy. No case is found in approximately 10% of patients. So these are the risk factors: hypertension, smoking, heavy alcohol abuse, heavy alcohol use, and sympathomimetic drugs are modifiable risk factors. Among non-modifiable risk factors are increasing age. Peak is in the 5th or 6th age. Female sex, African American ethnicity, Hispanic, Japanese ethnicity, prior history, family history, and history of aneurysm in the 2 or more first degree relatives, and other genetic conditions like autosomal dominant polycystic kidney disease, type 4 Ehlers-Danlos syndrome, and cerebral aneurysm more than 7 mm in diameter are the non-modifiable risk factors. Clinically, most commonly present such as headache, which is sudden and severe. We usually describe as worst headache of life. And headache is sometimes associated with loss of consciousness, nausea, vomiting, photophobia, and neck pain. In some patients, sentinel headache can be seen prior in hours or days prior to the main episode. And other symptoms are seizures, acute encephalopathy, concomitant subdural hematoma with or without associated head trauma. It's on physical examination, patient may be conscious or there will be decreased level of consciousness. Some patient may present as comatose conditions. There are meningeal signs and focal neurological deficits according to which may point us to the location of aneurysm. And in some patient, intraocular hemorrhage can be seen, and along with signs of elevated intracranial pressure. So these are the symptoms. Third nerve palsy with can be seen in PCOM aneurysm, and sixth nerve palsy can be seen in any aneurysm due to raised ICP. And bilateral weakness can be seen in anterior communicating artery aneurysm, hemiparesis with aphasia and neglect, seen in MCA, and nystagmus, ataxia, and dizziness in posterior circulation. So these are the common sites of aneurysm. MCA, anterior communicating, posterior communicating, basilar, ICA, and posterior inferior cerebellar. So this is a typical approach to the diagnosis, in which the patient typically presents such severe headache and a typical presentation like thunderclap headache, seizure, confusional headache, and associated head trauma can be seen. Initial investigation is head CT without contrast. If subarachnoid hemorrhage is found, then CT angiography or cerebral angiography is approached. If no hemorrhage is found and suspicion is high, and then lumbar puncture is performed, which if shows showing xanthochromia or elevated red blood cell count, we again proceed to CT angiography. And if it is a normal, then we can search for other etiology. Diagnosis is by CT aid, most rapidly available and appropriate initial diagnostic aid. It has high sensitivity in initial 7 days, from 93% in first 6 hours to 100% in first 12 hours to 93% on first day. And its sensitivity decreases with time to 60% at 7 days. Hyperdense blood in basal cisterns or sylvian interhemispheric or interpedicular fissures can point to aneurysmal etiology. It also rules out other etiologies presenting similarly, like hydrocephalus, intraventricular hemorrhage, and intracerebral hemorrhage. Lumbar puncture in case of negative or equivocal set head CT finding. On lumbar puncture, we check for opening pressure, and to differentiate a traumatic from 2SH, CSF should be collected in 4 consecutive tubes. Usually in the traumatic tab, the CSF count, the RBC count, or decreases in consecutive tube. Xanthochromia is seen usually by 12 hours by visual inspection, and sometimes it can also be done by spectrophotometry. MRI is considered equally sensitive in detecting subarachnoid hemorrhage in first 2 days. Except in first 6 hours, it is more sensitive than head CT. And GRE, SWR flare sequences have superior sensitivity to detect subacute or chronic subarachnoid hemorrhage. And other etiologies like AVM and inflammatory, infectious, and neoplastic etiology can be diagnosed on MRI. So once diagnosed, the identifying the bleeding source is important. So vessel imaging, gold standard is digital subtraction angiography, and but CT angiography is widely available and commonly performed as first line. It has sensitivity of 90 to 97% and specificity of 93 to 100%. CT angiography may miss aneurysm as small as 4 mm or less. Negative initial DSA. If there is a negative initial DSA, a repeat study 7 to 14 days after should be performed. In case of negative DSA, MRI of cervical spine to search for possible AV malformation of brain, brainstem, and spinal cord should be done. Some patients present with perimesencephalic subarachnoid hemorrhage, up to 15% of all subarachnoid hemorrhage, and 38% of them have non-aneurysmal perimesencephalic subarachnoid hemorrhage. It is non-traumatic and more benign. In rare cases, small aneurysm in posterior circulation and fenestration of vertebral and basilar arteries or anterior spinal artery abnormalities can be found. So, for the management of subarachnoid hemorrhage, 2 phases are considered. So, initial acute phase is diagnosis and aneurysm treatment in minutes to hours, and second phase is vasospasm period. So, and prevention of delayed cerebral ischemia. So, in initial phase, recognition of diagnosis, aggressive blood pressure control, and rapid diagnosis and initiation of aneurysm treatment, and securing aneurysm is important. In second phase, admission to neurocritical care unit and hemodynamic and oxygenation monitoring, protocolized and guideline-driven management, and clinical examination and monitoring for vasospasm should be done. The monitoring can be done using transcranial Doppler, multimodality brain monitoring, and medical and interventional therapy. So initial airway blood breathing and circulation should be done, and patient with coma in stupor from hydrocephalus seizures may need intubation. Rebleeding is a life-threatening complication, and a mortality of 20 to 60% is seen. It is highest within first 72 hours, 8 to 23%, and a majority of bleeding occurs within the first 6 hours. At later on at 3% per year. In the first minutes to hours, focus is on the prevention of the bleeding. The prevention of the bleeding is done by maintaining a blood pressure goal of systolic blood pressure less than 160 millimeters of mercury, and continuous blood pressure monitoring may be required. And blood pressure is usually controlled by continuous infusion more than bolus infusion. Nicardipine or labetalol may be used, and hydralazine is typically avoided. Antifibrinolytics uh, are not for long-term use. It can be used for short-term, up to 72 hours until aneurysm securement, and tranexamic acid or epsilon aminocapric acid can be used. Prolonged infusion are harmful. It can cause DVT, CVST, myocardial infarction, or stroke. So these are the scales for the monitoring the severity of subarachnoid hemorrhage. Major scale are World Federation of Neurology Society, Hunt and Hess and Modified Fisher Scale. It has 5 grades, and Glasgow Coma Scale and presence of motor deficit is used in World Federation of Neurological Society. In Hunt and Hess scale, level of alertness and severity of headache and cranial nerve and motor deficit is used. And modified Fisher scale is a imaging scale. Uh, it grades the subarachnoid hemorrhage based on the severity of subarachnoid hemorrhage and presence of intraventricular bleeding. Patient should be managed at a high volume center, meaning more than 35 subarachnoid hemorrhages cases per year, with experienced cerebrovascular surgeons, endovascular specialists, and neurocritical care services. And transfer to such a center should be initiated immediately. For aneurysm treatment, clipping or coiling are prepared. In ISAT trial, endovascular coiling group has significantly higher odds of survival-free disability at 1 year compared to surgical clipping, and it had also better outcomes even after 10 years. Risk of rebleeding and incomplete occlusion of aneurysm was lower with surgical clipping. So usually coiling is preferred, but in some cases surgical clipping is advisable. These include aneurysm with wide neck to body ratio and crucial arteries arising from aneurysm dome, and MC aneurysm and aneurysm with large parenchymal hematoma. In endovascular coiling, older age, poor clinical grade, multiple comorbidities, top of basilar aneurysm, high surgical risk, and aneurysms suitable for coiling or clipping are considered. In critical care management, subarachnoid hemorrhage is a systemic disease, and it is associated with systemic inflammatory response syndrome, which can cause long-term cognitive dysfunction, and it is also linked to non-convulsive seizures. Management of neurological and medical complications is important in ensuring survival. So neurological complications are hydrocephalus, brain edema, delayed cerebral ischemia, rebleeding, seizures, and neuroendocrine disorders with impaired regulation of sodium, volume, and glucose. Medical complications are cardiopulmonary fever, thromboembolism, glycemic dysfunction, hyponatremia, and anemia. Neurologic complication and management. Rebleeding is the most immediate life-threatening complication. Early and rapid treatment of unsecured and ruptured aneurysm is required, and aggressive blood pressure control is needed. Hydrocephalus, acute symptomatic hydrocephalus is in 20% of patients with subarachnoid hemorrhage. Usually occurs in minutes to days, and there is decreased level of consciousness, impaired gaze, impaired upgaze, hypertension, and delirium. It can resolve spontaneously in 30%. Otherwise, an external ventricular drain is required. Rapid weaning of external ventricular drain is recommended after aneurysm obliteration. or within 48 hours of insertion if the patient is neurologically stable. Placement of a chronic ventricular peritoneal stent may be required in later cases. In a small retrospective study from Germany, they said that dexamethasone 12 mg per day for at least 5 days may lower the risk of hydrocephalus after subarachnoid hemorrhage. In case of seizures, 26% patients may present with seizure-like episodes, and they are not easy to characterize as they occur at the onset of symptoms. If they occur prior to aneurysm securement, they are usually signs of early red bleeding, and long-term epilepsy is seen in usually 2% of subarachnoid hemorrhage patients, and non-convulsive seizures and non-convulsive status epilepticus in comatose patients are usually associated with delayed cerebral ischemia and worse outcomes. Some patients may need continuous EEG monitoring, usually in case of high-grade subarachnoid hemorrhage. Treatment with antiepileptic drugs should be limited to pre-aneurysm treatment time frame only, and later on tapered if there are no clinical indications, and they are usually needed in comatose conditions, and levetiracetam is usually preferred. And delayed cerebral ischemia is a leading cause of morbidity. Any neurological deterioration that persists more than 1 hour can be due to delayed cerebral ischemia, and it should not be explained by other neurologic or systemic conditions like fever, seizures, hydrocephalus, sepsis, hypoxemia, sedation, or other metabolic causes. An interaction of early brain injury and microthrombosis, cortical spreading depolarization, and repeated ischemia or cerebral vasospasm are the cause of delayed cerebral ischemia. It usually occurs up to from 3 to 14 days after subarachnoid hemorrhage, and with thickness of subarachnoid hemorrhage and intraventricular hemorrhage, its incidence increases. The associated risk factors are poor clinical grade, loss of consciousness ictus, cigarette smoking, cocaine use, systemic inflammatory response syndrome, hyperglycemia, hydrocephalus, and non-convulsive seizures. Predictors of patients requiring less frequent monitoring are the older age, low W World Federation of Neurological Societies scale, and modified Fisher scale of less than 3. For prophylaxis, nimodipine, which is a calcium channel blocker, is usually advised. It is 60 usual dose is 60 milligram every 4 hours for 21 days. It is a neuroprotective, and there is a class 1 evidence for decreasing risk of poor functional outcome. It does not decrease the frequency of angiographic vasospasm, and it can also cause hypotension, which may cause hypoperfusion and decrease cerebral perfusion pressure. Another important thing is to maintain and monitor U volumia. So as decreased intravascular volume and negative fluid balance is associated with higher incidence of delayed cerebral ischemia, poor neurological outcomes. Central venous pressure is a poor predictor of fluid responsiveness, but it is usually used for monitoring the intravascular volume. Another monitoring measures are pulse pressure variations and respiratory variability of inferior vena cava diameter. And prophylactic hypervolemia increases adverse cardiopulmonary complication and to be avoided. Combination of for monitoring of delayed cerebral ischemia, combination of neurological examination and imaging studies are used. Neurological examination should be frequent, every 1 to 2 hours, and delayed cerebral ischemia is suspected if focal or global neurological deficit or a decrease of 2 or more points on Glasgow coma scale that lasts for at least 1 hour. Transcranial Doppler is a longest used and best studied modality. It has adequate sensitivity and specificity to detect increased cerebral blood flow velocities in large vessels of circle of Willis. Vasospasm is diagnosed only if a ratio of mean cerebral blood flow velocity of the intracranial vessel to the mean cerebral blood flow velocity of the extracranial internal carotid artery is elevated. In case of MCA, it is more than 3 and called as Lindegard ratio, which is again a ratio of mean velocity of MCA to mean velocity of ipsilateral extracranial ICA. Monitoring is done by DSA, which is a gold standard for detection of large or middle-sized artery vasospasm. And another measures of monitoring is CT angiography. In some centers, CT angiography was CT perfusion is also used. Another monitoring measures are brain tissue oxygenation, microdialysis, and cerebral blood flow monitoring. And continuous scalp EEG can be also used. In some cases, angiographic or transcranial Doppler vasospasm can be seen in 70% of cases. In those without clinical manifestation, in those cases, wait and watch approach is taken, and very low threshold to trigger DSA or endovascular treatment is given. For management of delayed cerebral ischemia, nimodipine and eualimia are the main two measures. In case of low risk patient, frequent neurological examination, transcranial Doppler, and if CTA remains unchanged, they are shifted to step down unit. In high risk patient, they are shifted to other lower facility later. Rescue therapies for delayed cerebral ischemia, they are induced hypertension, hypervolemic, hypertensive or hemodilation, and hemodilation, that is triple H therapy is no longer recommended. Standard treatment is hypertensive and mild hypervolemic therapy, and IV fluid bolus 1 to 2 liter of normal saline, and maintenance fluid for eualemia or mild hypervolemia is maintained. Hypertension is preferred induced using norepinephrine or phenylephrine. Mean arterial pressure go down usually more than 20 millimeters of mercury above baseline.
Sumit, you will need to conclude now shortly.
So CT angiography and endovascular treatment are used in case of delayed cerebral ischemia. Prophylactic angioplasty, usually intra-arterial vasodilators can be used. Other important manifestations are cardiopulmonary. They are usually transient and range from mild ECG changes to severe reversible cardiomyopathy. Catecholaminergic surgery is the usual cause, and patient should be supported. For that, fever is to be managed, and DVT prophylaxis is usually initiated. Usually started with mechanical devices first, and after securement of aneurysm, then we can start the pharmacological prophylaxis. Glycemic dysfunction avoided. An important manifestation is hyponatremia. It is usually cerebral due to cerebral salt wasting syndrome and SIDS, which earlier is more common. Only differentiating finding is patient's intravascular volume status. Otherwise, all the parameters are same, and treatment is different. So differentiating the both of them is important. Anemia is to be managed.
I think please conclude.
Yeah.
Please conclude.
Yes, sir. So patient a subarachnoid hemorrhage is a life-threatening syndrome, and early management is important, and management in neurocritical care unit is important, and management of neurologic complications like hydrocephalus and delayed cerebral ischemia is important. Thank you, sir.
Fine. I've got one suggestion which I'll do in the during the end about the presentations. Rahul is here, so Rahul, can you hear us? Rahul is from the Pune group of the activity. Rahul, welcome. He's probably gone off. Yeah. Okay. Now, before I open for questions, we have a few 5 minutes for the questions. I have got one or two.
Satish, can
yes.
we request Sumit to stop sharing the screen?
Yes, Sumit, you stop sharing the screen. And I wanted to know, in our sort of collective experience, what percentage of subarachnoid hemorrhages that we see actually turns out to be aneurysmal? And when we see an aneurysm, what are the different etiological conditions that we have actually seen? I have a general feeling, not backed by statistics, that non-aneurysmal, or let's say non-demonstration of the aneurysm, is not all that uncommon in people with subarachnoid hemorrhages. So there are very senior people here.
So define this that you always do a repeat angiogram after 3 weeks intra-arterial DSA.
That's the next question. How many of us actually repeat the angiograms, and when?
I insist at 21 days.
Right.
At 3 weeks, I insist.
So what percentage?
Seven days, the teacher says, but I insist 21 days.
What percentage in the first angiograms will be negative in your practice?
Hardly any. Hardly any I pick up on the second time. Hardly any I pick up anything on the second time.
To be very frank, I don't think any of us have any collected data.
Correct.
That's true.
It'll be just off the cuff
anecdotal
percentage.
Yes.
But what I would request the participants, the people who are doing the study or taking this chapter, say for example Sumit, they have reviewed all the American data from the continuum. They should make an effort to review the Indian data and give us some Indian data. I'm very sure there is a lot of Indian data.
Yes.
Particularly, say from Sri Chitra and now in the north, because there are many centers which have neuro intervention. Yeah. So, whatever remarks Ashok wants to make now.
I have a controversial comment to make. Compared to your generation, Dr. Karthik, and compared to Sumit's generation, there is one very big major difference. People in your generation had a choice of endovascular versus surgery. And you could take a considered judgment depending on the location of the lesion. But in the modern generation, there are hardly any surgeons who are trained in aneurysmal surgery. Intervention, neurointervention, endovascular treatment is a treatment of choice. That is what is common in so many places, and it is actual invasive surgery is a rarity today. There are hardly any surgeons doing it on a routine basis.
But
routine
that should answer Satish's question much more.
Okay.
Because neurointervention won't go in with a negative angiogram for an aneurysm.
I'll tell you how at BH we have tackled this.
Okay.
We have made it mandatory when there is a subarachnoid hemorrhage. One interventional neurologist, the consultant under whom the patient is admitted, and one neurosurgeon review, and the report is given jointly by Rakesh Singh and Vikram Karmarkar, who is our vascular surgeon. So I think both of them sit and actually look at the pros and cons, and both of them together talk to the patient as to what is best for the patient.
That is the system, or it's the rule?
No, it's a system. Everybody doesn't follow the system because there are other interventionists, there are other surgeons, there are, but this is what we try and do. And we have found it a very balanced system. When the surgeon and the interventionist come together and have to sign the report together, then it comes
and what report, Satish?
The angiography report.
The angiography report.
Yes.
Okay.
Yeah.
And most important, recommendation.
Yeah, angiography report, and then at the bottom of it, their recommendation. Yeah. Jimmy, you want to say anything about the causes of aneurysm that you found?
No, I just wanted to confirm what you said, that I think this system gives us a feeling of good sort of safety, a good safety factor.
Yes.
A feeling that, we are doing what is best for the patient.
Yeah. So there are no other questions from the floor. So do we take
answer?
Yes.
Ashok Sirsat. There are very few neurologists left of my generation. You can count them on the tips of your fingers of one hand. So I think the question of my generation does not arise. I think the question of Sumit's generation does definitely arise. Now, I think the whole Indian Academy of Neurology is now fighting a court case to promote neuro intervention for the neurologists, neurosurgeons, etc. And it is getting to be a turf war.
Yeah.
The neuro interventionists do not want anybody to come into their turf because it seems to be a very remunerative
Yes.
aspect of
Yeah,
neurological.
yeah.
You
Whoever
know,
finishes
More and
DM,
more, it may
he
be
wants
more
to
and more
go.
remunerative
I
Yeah.
know.
as time
Great.
goes by.
So,
And Ashok, in the background, I like your Ganpati with your name.
lovely. So let's go on to the third presentation. Azad, before that, you want to tell them how to fill the Google Forms?
Yes, sir. So it's a short form. It won't take more than a minute or a minute and a half, and that will be the only evidence of attendance, and it's really important. So I've shared it on the WhatsApp Continuum group. If anybody wishes to have it personally on their email, or if anybody is not on that WhatsApp Continuum group, I'll just share my number for mobile number on the chat box. Just message me, and by the end of today itself, and by the end of every the Sunday, every time we have it, please spend that 1 minute and
Yeah,
send
I
it.
think best is to do it before you leave this thing. And there are 43 participants and 15 faculty members for Azad, generally for you to know how many forms come.
Let me just emphasize the importance of this forms.
Yes, sir.
You see, at the end of the whole session, or at the end of all the 6 continuums that we complete in a year, we accumulate all the forms and we send it to the London office of the WFN. Because these continuums are given free of cost to the WFN by the American Academy of Neurology. And they also have to give a report back to the American Academy of Neurology. Therefore, to show the worldwide use of this Continuum CME program, I think they require a feedback through the forms. So please fill up the form. I think it is your duty to fill up the form because you're getting a continuum free of cost. You know? So please do that. All right?
Yeah, I think it's important. So we go on to the third presentation, status epilepticus, Karthik. Karthik from Just Look.
Good morning, everyone. My slide is visible?
Yeah, but your voice is
loudly, little loudly,
Yes, yes.
or use the mic very close to your mouth.
Hello, now is it okay, sir?
No, it's still low.
1 minute. Hello?
Yeah, it's a
Hello?
little bit better, Karthik.
Hello?
Karthik, you go ahead. We'll see how it goes.
Okay.
You start.
Okay. So, good morning, everyone. So, next 20-25 minutes, I'm going to discuss about status epilepticus and what is new in the management of status epilepticus. Okay. So, outline will be introduction, definition, classification, physiology, diagnosis, and workup and treatment. So let's start with introduction. So as we know, status epilepticus is an epilepsy emergency with a clear time-dependent relationship to morbidity and risk of mortality. However, the status epilepticus is not a single entity. It has number of different form and vast area of etiology. So overall annual incidence is around 10 to 41 per 1 lakh population. And there is a bimodal peak distribution with peak in the children and elderly, and frequency of refractory that we'll see in the subsequent slide what is refractory status epilepticus and supra-refractory status epilepticus. The frequency of refractory status epilepticus in status epilepticus patient is around 31 to 44%, and out of this 20% will become a super-refractory status epilepticus, and approximately 50% cases there is a no prior history of epilepsy, that we call is a NORS, or new onset refractory status epilepticus. Mortality range between the 10 to 28% of status epilepticus, and neurological and cognitive sequel in convulsive status epilepticus occurs in 11 to 16% of patients. So now come to the definition. So in the past there were multiple definition was given, but now what is accepted is as per Neurocritical Care Society and American Epilepsy Guideline is. So what is convulsive status epilepticus? So it's a convulsive status epilepticus is either 5-minute or more of continuous seizure activity, or 2 or more discrete seizure between which there is a incomplete recovery of consciousness. Now, what is refractory status epilepticus? It's referred to either clinical or electrographic seizure that persist for 30 minutes after adequate dose of the initial benzodiazepine and an acceptable second-line anti-seizure drugs, that is levetiracetam, valproate, and phenytoin. And what is super refractory status epilepticus? It's defined as a status epilepticus that continues or recurs 24 hours or more after the initiation of anesthetic therapy. Okay, so how do we classify status epilepticus? So status epilepticus mainly divided into two: convulsive status epilepticus and non-convulsive status epilepticus. In non-convulsive status epilepticus, we have post-convulsive, non-convulsive status epilepticus. Non-convulsive status epilepticus in patients who are critically ill or comatose, or non-convulsive status epilepticus in patients who are ambulatory. So we can further subclassify into based on the clinical presentation, like generalized tonic-clonic presentation, or epilepsia partialis continua, or psychogenic status epilepticus, or myoclonic status epilepticus. In non-convulsive, we can again generalize non-convulsive. Okay, so what is etiology? So this is the table given in the continuum. So there are some acute causes and chronic causes. And acute causes, they mentioned acute stroke, trauma, infection, hypoxic brain injury, posterior reversible encephalopathy syndrome, autoimmune and paraneoplastic etiology, sepsis, metabolic, drug withdrawal, toxicity, or non-compliance. In chronic causes, they have mentioned about non-compliance of drug, brain tumor, and previous brain pathology. If we see out of this, if we have to pick up 3 or 4 most common causes, so it will be non-compliance or low level of the anti-epileptic drug should be first, followed by infection and metabolic causes. That also our Indian data also show. So this is the article published in the Emergency Trauma and Shock Journal by Dr. Rimi Shaw and Dr. Ashish Palla. So this is a prospective study done from January 2009 to December 2020. So they have included 80 patients, and mean age of the patient around 39 plus or minus 70 years. So what they have found that the majority of patients have convulsive status epilepticus, and the most common cause or poor drug compliance was found in the 50% of patients, and followed by the central nervous system infection. And alcoholic intake, they have found third causes, and some precipitating factor that could not be traced in 7.5% of patients. This is the another study from the India, which saw the clinical, radiological, and outcome study of the status epilepticus published in Neurology of India by Dr. P.P. Nair. So they have also included children and adult. They have included 22 children, 77 adult, and 18 elderly patients. So in the children, age is less than or equal to 12, and in the elderly, age was more than 60. So what they found that etiology of status epilepticus was infection in 53.8% of patients, drug default in 7.9% of patients, metabolic in 14.5% patients, and stroke in 12.8%, and miscellaneous in 11% of patients. So what they found that infection as the etiology was most common in the children, and drug default and metabolic causes more common in the adult, and stroke is more common in the adult as well as in the elderly. Okay, so what is pathophysiology? So as we know that most of the seizure will spontaneously stop, but what leads to seizure status epilepticus or refractory status epilepticus? It is because of the imbalance between the excitatory and inhibitory neurotransmitter balance. As we saw in this diagram, this presynaptic neuron and postsynaptic neuron, the green it is GABA receptor, and the red one is the NMDA receptor. So what happened at the seizure start, initially there is a more GABA receptor on the postsynaptic neuron. So that's why at the start of the seizure, seizure will respond to the benzodiazepine or barbiturates, and the seizure progress. GABA receptor is replaced by the NMDA receptor. So that's why at some point of time the barbiturates resistance comes and seizure will not respond to the our first line anti-seizure medication, and 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 because of this there is a excitatory glutamate and NMDA neurotransmitter toxicity, and it will lead to neuronal death and seizure propagation to status epilepticus. Okay, so what is the systemic and cerebral pathophysiological changes with status epilepticus? As we know, in the early 30 minutes, there is a compensation by increase the cerebral blood flow, increase cerebral energy requirement, which matched by supply of oxygen, glucose, increase glucose concentration in the brain, increase catecholamine release, and increase cardiac output. If seizure continues, the decompensation occurs after 30 minutes, and that will lead to failure of the cerebral autoregulation, hypoglycemia, hypoxia, acidosis, hyponatremia, hyperkalemia, disseminated intravascular coagulation, leukocytosis, falling in blood pressure, or falling in cardiac output, or rhabdomyolysis. Okay, so how we can diagnose a patient with status epilepticus? So in the convulsive status epilepticus, it is straightforward. So tonic phase is initially prolonged and is followed by the clonic movement are violent. And the convulsive phase is mostly accompanied by the sympathetic manifestation like the pupillary dilatation, tachycardia, hypertension, hyperglycemia, and increased cerebral blood flow. And as the status epilepticus continues, the tonic phase shortens as the clonic movement disperse and ultimately disappear. And sometimes with ongoing non-convulsive seizure activity occurs, and this stage referred to subtle status epilepticus. So what is important is to diagnose the non-convulsive status epilepticus. So if the convulsive activity never occurred and was not observed, then identification of the generalized non-convulsive status epilepticus require a high index of suspicion, because the generalized non-convulsive status epilepticus in adults appears in several clinically distinguishable forms like the stupor or coma with generalized electrographic epileptic activity, or it could be focal non-convulsive status epilepticus with secondary generalization, or it could be due to subtle status epilepticus. So and out of this most difficult to diagnose is focal non-convulsive status epilepticus, because it can present in different way, like any behavioral changes, cognitive, sensory, autonomic, or motor symptom are predominant, and the patient is typically awake and confused and may appears to have somewhat automatic behavior such as walking or performing simple tasks repeatedly. Additional common manifestation include unresponsiveness, speech arrest, stereotype automatism, and eye deviation, nystagmus, or blinking. So diagnosis of both focal and generalized non-convulsive status epilepticus require clinical suspicion, EEG confirmation, and both clinical as well as electrographic improvement following a trial of fast-acting anti-epileptic drug. So as per Neurocritical Care Society guideline 2020, they have given class 1 level B recommendation. What is the indication of EEG? So they have mentioned the patient who had suspected seizure in patient with unexplained coma or altered mental status, or recent clinical seizure activity, or status epilepticus without return to the baseline within 10 minutes. So in this condition, you have to do a EEG monitoring. Okay, so this is the clinical criteria to diagnose the non-convulsive status epilepticus. So they have divided into two categories: the patient without non-epileptic encephalopathy and the patient with non-epileptic encephalopathy. So in the epileptic encephalopathy, they have mentioned that epileptic from discharge is that more than 2.5 hertz, or epileptic from discharge is less than or equal to 2.5 hertz, or rhythmic delta or theta activity, and one of the following like EEG and clinical improvement after IV anti-epileptic drug, or subtle clinical ictal phenomena during an EEG pattern mentioned above, or typical spatio-temporal evolution. Or in the non-epileptic encephalopathy, the above mentioned plus when it's compared to baseline with observable change in the clinical state, or improvement in clinical or EEG feature following the IV anti-epileptic drug. Okay, so as we know, workup mostly basic, apart from basic worker, we have required some blood tests like iodine, calcium, magnesium, CT scan, MRI, depending on the structural etiology, lumbar puncture, toxicology screening, and some other investigation like the autoimmune panel in case of the refractory or super refractory status epilepticus. Now coming to the most important part is treatment. So what is the goal of our treatment? It should be termination of the status epilepticus, prevention of the seizure recurrence, management of a precipitating cause, and management of complication. So unfortunately, even for the convulsive status epilepticus, they are limited randomized controlled clinical trial, and therefore the treatment algorithm are largely based on the expert opinion. Okay. So we have two guidelines. This is the Neurocritical Care Society 2020 guideline and American Epilepsy Society 2016 guideline. So both the guidelines are more or less same. Apart from what the Neurocritical Care Society is, it tells that you should aggressively treat the patient. So they recommended the early first line benzodiazepine, like within the 5 minutes. Like we have first line benzodiazepine, IV lorazepam, intramuscular midazolam, or IV diazepam. And what in the American Epilepsy Society does, it should be started between 5 to 20 minutes. Apart from them, second line we have fosphonitoin, valproate, phenobarbital, and levetiracetam. So and after that, for the refractory status epilepticus, we have IV anesthetic agent. So and one another change that in the Neurocritical Care Society, they have recommended phenobarbital as a second line. But what American Epilepsy Society tell that you should use first three: fosphonitoin, valproate, or levetiracetam. If none of are available, and then you should go for the IV phenobarbital. Maybe because they are more concerned about the side effect. Okay. So now we have three first line benzodiazepine. That is lorazepam, intramuscular midazolam, and IV diazepam. So which is better? What we should use first? So this is the trial done by the Dr. Robert and Dr. Daniel Lowenstein rampart trial. So it's a rapid anticonvulsant medication prior to arrival trial. So it's a double-blind randomized control clinical trial to check the efficacy of the intramuscular midazolam versus intravenous lorazepam in the pre-hospital treatment of status epilepticus by paramedics. So what they have used 10 milligram dose of the intramuscular midazolam versus 4 milligram dose of IV lorazepam, and this is pre-hospital treatment. So they have included more than around 900 patients, and then divided into two groups. The midazolam group, there is a 448 patients. In the lorazepam group, there are 445 patients. So what they found that the seizure terminated in the 329, that is 73% patient in the IM midazolam group, and in the 63% patient with the IV lorazepam group. What after reaching the hospital, like 40% patient require endotracheal intubation in the intramuscular midazolam group, and same in the IV lorazepam group. Out of these, 58% in the intramuscular midazolam group require subsequent hospitalization, and 66% patient in the IV lorazepam group. And the seizure recurrence is found in the same, both group, 11% seizure recurrence found, and in hypotension seen in the almost same, 2.7% in the intramuscular midazolam group and 2.9% in the IV lorazepam group. So what they've said that the primary efficacy endpoint would achieve in 73% of subject in the intramuscular midazolam group compared with 63% in the IV lorazepam group, giving the absolute difference between group was 10%. So marginally they have said the intramuscular midazolam is better as compared to IV lorazepam. It's because they have started midazolam as early, and in case of the IV lorazepam, we have to require to assess the intravascular IV cannula. So they found. So they found marginally better in intramidazolam group. Okay. So now second line group anti-seizure medication, that is levetiracetam, fosphonitoin, and valproate. So this is the ASSET trial, established status epilepticus treatment trial. So recently published in 2019. So what they have done, they have included the 384 children and adult patients with benzodiazepine refractory status epilepticus, and then they have used a dose of levetiracetam 60 milligram per kg, dose of fosphonitoin 20 milligram per kg, and valproate 40 milligram per kg. And what they found that the almost same in the three group, that absence of clinical evidence seizure and improved responsiveness is 60%, 60 minutes, 47% in levetiracetam group, 45% in fosphonieton group and 46% in valproate group. So they found no significant difference in the rate of seizure cessation or in the safety. So this is the safety assessment of the three groups. So we can say that side effect, life-threatening hypotension seen in the one patient in levetiracetam group, 4% in fosphonieton group, and 2% in valproate group. Cardiac arrhythmia seen in one patient in levetiracetam group and 64, that is 14% patient of fosphonieton group. Like they require endotracheal intubation in 30 or 20% patient of levetiracetam group, 26% patient of fosphonieton group, and 17% patient in the valproate group. And acute seizure recurrence they found almost same, 11% in all three groups, and the acute respiratory depression they found in 8% in the levetiracetam group, 13% in the fosphonieton group, and 8% patient in the valproate group. And what they found that seizure not terminated in the 40% of the cases. So all these patients subsequently required the IV anesthetic agent. Okay. So this is the some systemic complication of the status epilepticus. We have to also monitor and manage these patients to improve the morbidity and mortality that are like musculoskeletal injury, renal injury, cardiac injury, and pulmonary injury due to aspiration. Okay, so now come to the refractory status epilepticus. So as we saw, this refractory status epilepticus is either clinical or electrographical seizure that persist for 30 minutes after adequate dose of the initial benzodiazepine and acceptable second line anti-seizure. It, as I mentioned earlier, it's a 40% of the status epilepticus are refractory status epilepticus, and predictors are like I mentioned earlier, the low anti-epileptic drug, infection, non-structural causes like hypoxic ischemic encephalopathy causes, and delayed diagnosis and treatment. Okay, so what we have in the management. So again, with what are the problem in the treatment, because we have no randomized control trial, we have small case series, and the inclusion criteria in all these small case series are also different, and the treatment protocol depend on the seizure control and toxicity. So this is the one article I found by Dr. Zhang and Yu, published in BMC Neurology. So they review the systemic review and meta-analysis of propofol versus barbiturate for controlling the refractory status epilepticus. So they have included 261 patients, and what they have found that propofol shortened the average seizure control time and the reduced average tracheal intubation placement time with significant p-value of refractory status epilepticus more extensively than did the barbiturate, and did not increase the incidence of the hypotension. But this is a small case series, but and again in the old study they are small and they done in the retrospectively with similar complications. So we need a further randomized control trial. Okay, so they are the commonly used anesthetic agent in the refractory status epilepticus like midazolam, propofol, phenobarbital, and ketamine, and they are the loading and maintenance dose and side effect. I think now we are using this anesthetic agent mainly because we are also based on that side effect profile. Like the midazolam are known to cause respiratory depression and hypotension. Propofol are known to cause hypotension and propofol infusion syndrome. Phenobarbital are cause hypotension, respiratory depression, hepatotoxicity, and ketamine, as we know, they are known to cause increased intracranial pressure. Okay, so what is the role of lacosamide? So lacosamide is now available and we are using quite frequently. So this is the study done by the Dr. Julia and Eugene. Lacosamide is a new treatment option in the status epilepticus. So they have also reviewed the 19 study and included the 136 patients with refractory status epilepticus. And out of this, there 50% patients have non-convulsive status epilepticus, 31% patients have focused status epilepticus, and 90% patients have convulsive status epilepticus. So they have treated lacosamide with bolus dose around 200 to 44 milligram over 3 to 5 minutes. And what they found is overall success rate of 56%. And also, as we know that lacosamide are known to cause prolongation of PR interval. So they have on some of the patients have cardiac side effect like the AV block and paroxysmal systole, and some another side effect like mild sedation, angioedema, allergic skin reaction, hypotension are noted. So what they have concluded that the current evidence of use of IV lacosamide in acute seizure and status epilepticus is restricted to retrospective case report and case series, and further prospective study are needed to confirm the what is the exact role of glucosamide in the status epilepticus. Okay, so since we are using the IV anesthetic agent to patient who in the refractory status epilepticus, so what is the exact duration that we should use to treat the refractory status epilepticus? So there is a one uh, hypothesis that you should use burst suppression to monitor the IV anesthetic agent. So let's couple of slides about burst suppression. So what is burst suppression? It's a high voltage burst of the slow wave, that is theta and or delta with intermediate, sharp, transient and spike against the depressed background or complete flatness. So we can see this is the burst of slow wave followed by the flatness. So does burst suppression achieve seizure control in refractory status epilepticus? So this is the article published by Dr. Suprat and Dr. Kenneth Kong in BMC Neurology. So what they have did, the aims was the midazolam induced burst suppression on the occurrence of outcome in refractory status epilepticus patient. So they have included the 51 non-anoxic encephalopathic patient with refractory status epilepticus, and they divided into two groups: burst suppression group that include 26 patients and non-burst suppression group that include 25 patients. So what they have found that breakthrough seizure is seen in 26% of the patient with burst suppression group and 96% patient with non-burst suppression group, and with significant p-value. But they have also found that withdrawal seizure are more common in the burst suppression group, that is 54% patient, as compared to non-burst suppression group, that is 28%. And with similar complications like cardiac, pulmonary, and fever infection in the both the group. And they have found the mortality is higher in the burst suppression group, that is 53.8%, and non-burst suppression group is 24% with significant p-value. So what they have said is burst suppression is safe and associated with the less breakthrough seizure, but additionally it was not associated with a increased rate of intra-hospital complication or long-term outcome. So we are not sure if we should use the burst suppression to monitor refractory status epilepticus. Okay, so now coming to super refractory status epilepticus. So as I mentioned earlier, it's a status epilepticus that continues or recurs 24 hours or more after initiation of the anesthetic therapy, and it's also include the cases in which the status epilepticus recur on the reduction or withdrawal of the anesthesia, and it is out of as we know, the super refractory status epilepticus is not common. It's only 20% of the refractory status epilepticus patient, and it needs combination therapy, that is AD and anesthetic group, and it has high mortality and morbidity with limited proven therapy. Okay. So as I mentioned earlier in the pathophysiology, that as the seizure progresses, in the postsynaptic receptor, NMDA receptor become more prominent. So this comes the role of the ketamine. So as we know, ketamine acts to the NMDA receptor. So there are two enantiomer of the ketamine, R and S. Out of this S enantiomer of the ketamine, it is more potent and has a rapid onset of action. So that's why this group of Dr. Julia and Dr. Alenza use a S enantiomer of ketamine in the refractory and super refractory status epilepticus. So they have done a retrospective study in Austria from 2011 to 2015, including 42 patients. So in that study, that median duration of the status epilepticus was 10 days, and the median latency from the status epilepticus onset to first administration of the ketamine was 3 days. And so what they found that in the 64% of the patient was the last drug was ketamine before the status epilepticus cessation, and the median duration of the administration was 4 days, and in 5 patients it was also given propofol at the same time. So they are not sure in that 5 patients. So overall they've said that the ketamine treatment was well tolerated and adverse effects were not observed, and overall mortality was 45.2%. And what is the other option? That we have other intervention option for super refractory status epilepticus. So ketamine, as we already discussed. Another is we have isoflurane, but it's isoflurane. We have limited data about isoflurane in the super refractory status epilepticus. Ketogenic diet is also one promising, but compliance is extremely difficult with long-term use of diet because of the social and dietary restriction, and we have no well-designed hypothermia. So hypothermia, yes, we have good evidence. So hypothermia can potentially be used as an alternative to two or more unsuccessful EEG burst suppression trial, and the goal of the temperature of around 30 to 35 degrees Celsius for 24 hours. And what are the other non-pharmacological options we have, like electroconvulsion therapy, transcranial magnetic stimulation, and vagal nerve stimulation. But again, we have no strong evidence, and further study are needed to justify their role in the super refractory status epilepticus. Okay, so now what is the role of autoimmunity? So now we have more autoimmune encephalitis, and we are finding more and more new antibodies. So when to suspect a role of autoimmunity in status epilepticus? So when there is a new onset seizure, a progression to refractory or superactive status epilepticus, absence of established epileptic history, and associated with other neurological program like memory loss, hypothalamic dysfunction, new psychiatric symptom, non-history of cancer, and lymphocytic pleocytosis. Yeah. Yes.
Karthik,
Yes,
you
sir.
need
Couple
to
of
conclude.
yes, sir.
Yeah.
Yes. Yeah. And the other two score, like antibody prevalence in epilepsy of unknown etiology score, and another response to immunotherapy in epilepsy score. It's to prognosticate the autoimmunity in the status epilepticus, and how to manage the non-convulsive status epilepticus. So there are no universally accepted definition. It's purely based on the patient mental status and clinical course. And this is the diagram given in the to continue to how we can approach to non-convulsive status epilepticus, and the, what these two terminology, NORS and FIRE. So as we know, new onset refractory status epilepticus, as I mentioned earlier, and what is FIRE? So FIRE is a subcategory of the NORS that require a preceding febrile infection with fever starting between 2 weeks to 24 hours before the onset of the refractory status epilepticus. So no known underlying mechanism was found, but it could be fulminant inflammatory response in the central nervous system. So what is the role of immunotherapy? So in this study by the Gaspard, they have used steroid immunoglobulin in the patient with cryptogenic FIRE and cryptogenic NOR patient, and they found that with the partial improvement in patient with the FIRE and NORS with the steroid and intravenous immunoglobulin. And they have also used the hypothermia, rituximab, azathioprine, tacrolimus, cyclophosphamide with minimal improvement. Okay, so still we don't know which anesthetic agent to be used, when should be anesthetic agent be used, what is the optimal dose of anesthetic use, what are the optimal duration of the use of anesthetic agent, should EEG monitoring be used in the all cases of refractory status epilepticus, what is the goal of the anesthetic treatment, is burst suppression of the seizure, or suppression of the all EEG activity, or what is the role of the combination or the cyclic anesthetic agent use. Okay, so the take home message, as I mentioned, that you need to treat as early as possible. First line we have benzodiazepine, maybe out of hospital treatment. Established status we have 3 second line anti-epileptic drugs. In refractory we have intravenous anesthetic within 30 minutes of hospitalization, and EEG monitoring is required, and query role of the burst suppression in the refractory status epilepticus. Okay, so as we know in the field of medicine,
Tell.
No.
Tell. Yeah.
So as we know in the field of medicine, there are so many things we still don't know, and we are learning something new every day. So that's why Henry David said, when any real progress is made, we unlearn and learn anew what we thought we knew before. Thank you.
Yeah, thanks. Thanks, Karthik. I think we are a little bit short of time, so maybe we'll take a comment or two from the faculty and then move ahead. Jimmy, you want to make any comments on status? Or Ashok wants to?
Yes, the question is to you, Dr. Kharelkar.
Yes.
It came about the last time when we had a discussion on status epilepticus in the Continuum meeting.
Yes.
We came out with a phenomenal comment. And I think I want you to explain this a little more in detail for this audience. You said that we have a 3-tier way of management. You have benzodiazepines either before they leave the ICU, before they leave the hospital, or just after they leave the hospital and be on the bed. The second tier would be anticonvulsants, and now the literature says either it's levetiracetam or phosphonatoin or valproate. It doesn't make a difference. And the third tier of treatment would be propofol or ketamine or whatever your anesthetist is more familiar with. what you said is too much time is wasted to go from tier 1 to tier 2 to tier 3. And I want to know if you change your mind. You said you should quickly go into tier 3 and not waste your time too much on tier 1 and tier 2.
I think if your center is good and you're not too worried about the complications that these big drugs will produce, I think one should move quicker. Also, one more caveat based on the case. Like if you have somebody who is a known epileptic, has missed the medicines and has come, then giving the same medicine probably will hold him, most of the time that will happen. But if you have a Norse situation, there is no point waiting for the graduating from one to the other, I think. But again, that means the judiciousness of the clinician comes in. Yeah. But this is a perpetual dilemma, no? Scaling up treatment versus scaling down treatment. Scaling down is give everything and then say, okay, cut out once the patient is better. And scaling up is, oh, I'm cautious, these drugs are bad. And so it's as much to do with the doctor's mindset.
Time is wasted. Too much time is wasted between
tier
1 and tier 2.
I agree with you.
I think a really good setup is very necessary. Then we can definitely, go into
be more adventurous
very quickly. If we have our intensivists on there, because there are complications with these tier 3 drugs. But yes, if we have that, I think we certainly should move faster. I agree. I mean, if they keep continuously convulsing and you keep giving the same second tier drugs, that's probably not appropriate.
Yeah. Also, I think there is some Indian data which could have been shown. We will talk about it in the end, but there is data from NIMHANS to show that how much time it takes for the people from their homes to the hospital in the real world in India, and therefore what should be promoted. So I think those articles are worth bringing out because we work here.
Sure.
Okay, so Dr. Katrak wants to say, make any comments, sir?
To ask Ashok, basically I am out of all these acute neurology for the last several years, even before I retired. So I'd like to ask Ashok, would you give the third tier drugs and wait for hypotension or the other complication, then start withdrawing? Or, because I personally feel maybe my generation is a little more conservative and therefore we like to go stepwise upwards rather than hit very hard and then face the consequences of the complications.
Yeah, I think there is no foolproof system. It just goes based on the doctor's idea, the family's idea, the disease. So all these three components are variable in every situation. So I think the outcomes every time will be, and the methodology will be every time different.
I think personally, I feel what you said is very correct, Satish. It depends on the etiology of the state.
Yeah.
True.
Yeah.
As you said, if it's drug withdrawal, then going for the same drug in an intravenous mode, and all the three drugs are equally effective.
Yeah.
So there's no point. If he's taking one of those drugs, then it's best to give one of those drugs intravenously and then deal with the situation.
True.
Yeah. So let's move on to the fourth presentation. Varun Deshmukh from Jaslok, Management of Cardiac Arrest Survivors. Varun, please keep to your 20 minutes. We are a little above time.
Sure. Thank you, sir. Good morning, everybody.
Arun, can we get a look at you?
Yes, sir. So my slides are visible?
Yes.
Yes, they are. Yeah.
Okay, so we will discuss about the management of cardiac arrest survivors. The outline will be introduction, following that goal of care and prognosis. Cardiac arrest results in over 5 lakh deaths per year in North America alone. Advances in CPR and post-cardiac arrest care have improved the outcomes in select cohort of patients. And among these advances, the use of therapeutic hypothermia and targeted temperature management, along with other interventions to improve the care of patient following cardiac arrest. These are the main points. The goals of care, major goals of care are determining the cause of arrest first, minimizing brain injury, managing the cardiovascular problems, managing problems arising from global hypoperfusion and reperfusion injury, and general critical care. So what are the immediate threats following the return of spontaneous circulation? Immediate threats include cardiovascular collapse, oxygenation and ventilation, electrolyte imbalance, which may be the cause of cardiac arrest in the first place or may have occurred following the return of spontaneous circulation. At the same time, we have to minimize brain injury and also manage other problems which are due to comorbidities of the patients. So these are the common etiologies of cardiac arrest, most common being acute coronary syndrome. Following that, arrhythmia secondary to electrolyte acidosis or other problems, sometimes prolonged QTC, pericardial tamponade. In respiratory, obstruction of the airway, asthma, COPD exacerbation, pulmonary embolism, tension pneumothorax, hemorrhage and hypovolemia. Causes include trauma, GI bleed, aortic aneurysm rupture, IC bleed, profound GI fluid loss. Drugs and poisons like opioids, beta blockers, calcium channel blockers, benzodiazepines, TCA, digoxin, and electrolyte imbalance, mainly potassium and magnesium. And also sepsis is a possible cause in some of the cases. We have to take focused history and focused physical examination. Most of the situations, patient will not be able to give history. He would be unconscious. So family of the patient, bystanders or paramedics who brought the patient would be able to give some history, what was happening when they reached and what was the scenario. We have to maintain the airway, breathing and circulation of the patient. Look at the patient from the point of view of ruling out any major bleed, any bleed in the mouth or pharynx, and any rectal bleeding or external bleeding we should see. Any evidence of DVT or marks of IV drug abuse, we should look at. Sepsis, fever, and any other evidence of sepsis. And at the same time, we should do baseline neurological examination once ROSC is achieved. Asymmetrical neurological findings are not expected following ROSC, and they suggest a structural intracranial lesion. Brainstem responses, including pupillary, corneal, oculoencephalic, gag, and cough response to stimulation, correlate with survival and should be assessed. The Glasgow score or full outline unresponsiveness 4 score should be determined with particular attention to motor score, which correlate closely with neurological outcome. Patients who cannot perform purposeful movement or follow basic commands generally need specialized neurocritical care, including therapeutic hypothermia or targeted temperature management. So these are the few risk factors, neurological risk factors after cardiac arrest. So the shorter the interval of no flow, means the arrested period, the shorter the period, the better the outcome, the low the risk. The total ischemia time means the no flow plus quality of CPR. So the better the quality of CPR, the sooner the ROSC, the risk is low. Motor examination. So if the motor subscore is more than 4, or the total Glasgow score is more than 5, the outcome would be a little better compared to the other scenario. 4 score means if the pupil and corneal reflexes are absent, that is a poor prognostic sign. And in CT also, if the gray white matter differentiation effaced is there, then medium to high risk of neurological injury outcome. Compared to that, if gray white differentiation is severely effaced, very high chances that the patient would have neurological sequelae. Subarachnoid hemorrhage would also be not a good finding. EEG background at 4 to 18 hours. So continuous has a low or medium risk. Compared to that, non-reactive EEG has high risks. Burst suppression has high risk of neurological injury. Isoelectric has very high risk, and low voltage is unreliable. Processed EEG in patient who received neuromuscular blockade post return of spontaneous circulation. So bispectral index is used, and bispectral index more than 20 is a good marker, and it is having low neurological risk. Bispectral index lower than that contains risk. Separation ratio at 6 hours after resuscitation So less than 10% would be having a good neurological response. Compared to that, as it goes up, the neurological risk would be higher. And early onset severe myoclonus with EEG correlate has a poor neurological outcome. Frequent periodic epileptic form discharges or seizures arising from a suppressed background has a poor neurological outcome. Now the diagnostic studies in general. So we would do an ABG with lactate to begin with and would repeat it every 6 to 8 hours depending on the previous value and patient's clinical condition. Baseline tests like CBC, electrolytes, liver and kidney function should be done, PT, PTT. Serial troponins, generally when patient receives CPR, the troponins would be above normal, but doing serial troponins might indicate ongoing myocardial injury. ECG would show ST elevation or new onset LVBB, so that would indicate that this is probably ischemic in nature. The onset of cardiac arrest would be because of cardiac ischemia, and new onset arrhythmia can be detected on the ECG. Chest X-ray would show aspiration, which would be common in such scenario, or earlier patient would be having pneumonia, so that would be seen, and pulmonary edema can be seen on the X-ray. Other imaging, preferably bedside USG and echocardiography, will give us clues about life-saving problems like tension pneumothorax or cardiac tamponade or massive PE or a regional wall motion abnormality in the left ventricular contraction, or there can be intraperitoneal bleed which would be detected in the bedside ultrasound. Generally, CT pulmonary angio would not be done in such patients if they are hemodynamically unstable and if the echo itself is showing evidence of massive pulmonary embolism. But CT pulmonary angio is also needed sometimes. CT brain for if we cannot find any obvious cause of the cardiac arrest, CT brain and some focal signs would be seen. Then CT brain may have to be done, which may show early cerebral edema or intracranial hemorrhage. And based on the scenario, toxic screen might be needed in such cases to diagnose the cause. We have to intubate and ventilate these patients. We have to maintain saturation more than 94% and PCO2 around 40. Lower PCO2 would lead to hypocapnia, and that would lead to cerebral vasoconstriction. So we would target a PCO2 of normal around 40. Hyperoxia means PaO2 more than 300 is also associated with mortality amongst patients who revive following cardiac arrest. So oxygenation should be normal, PaO2 should be around 100 and saturation should be above 94. We should not aim for hyperoxia. These patients generally would require a central line and arterial line. We have to assess volume status and replace the volume. Generally, we start with crystalloids, normal saline or Ringer's lactate. We should avoid hypotonic fluids like 5% dextrose, which would worsen cerebral edema. Vasopressants and inotropes. So initially crystalloids, and once the volume status is filled, we may have to start vasopressors, noradrenaline being the first option. And for the inotropic effect, we may have to add dopamine or milrinone. And if the cause of arrest is cardiac in nature and doing all this is also not helping, perhaps we may eventually resort to mechanical support like IABP or ECMO. So now the hemodynamic considerations for such patients. So mean arterial pressure should be kept above 65 in acute shock state, and preferably 80 to 100 to optimize cerebral perfusion. We have to simultaneously balance the needs of ischemic brain with potential for overstressing the decompensated heart at this point. Generally, with this situation, the cerebral autoregulation is impaired and brain perfusion declines when MAP falls below 80 to 100. So we have to maintain good MAP to maintain good cerebral perfusion. Maintaining CVP between 8 to 12 and maintaining urine output more than 0.5 ml per kg per hour are also additional perfusion goals. So when the patient has obvious STEMI or new onset LVBB or RWMA on the echocardiography or serial rise in tropi, these patients would benefit from cardiac catheterization. Several studies have reported that cardiac arrest patients treated with coronary catheterization were twice as likely to be discharged home or to acute rehabilitation compared to not so treated. Even without coronary revascularization, medical treatment would also be beneficial. So depending on the facilities available at the center, we should go for the treatment. Coming to the targeted temperature management and therapeutic hypothermia, neurological injury is the most common cause of death in patients with out-of-hospital arrest and contributes to mortality of inpatients arrest as well. Cerebral edema is frequently lethal complication, and it is seen in around 22 to 50% of patients post cardiac arrest. Induced hypothermia, around 32 to 34%, reduces the ICP and prevents herniation in patients with intracranial hypertension after SH, traumatic brain injury, cerebral edema from hepatic encephalopathy, and ischemic stroke. And also there is some data on benefit of low temperature in reducing seizure frequency. So that is the logic of applying it here also. This was a trial published in AEGM in 2004. Treatment of comatose survivor of out-of-hospital cardiac arrest with induced hypothermia. So here they took 77 subjects and they reduced the temperature, core body temperature, to 33 degrees within 2 hours after return of spontaneous circulation. And they found that there was a significant improvement in the mortality as well as in the neurological function in out-of-hospital setting. So for clarification, therapeutic hypothermia refers to temperature of 32 to 34 degrees Celsius at the core, and temperature control means temperature less than 36, but may not go up to 32 to 34. At the same time, we must note that hyperthermia must be avoided because failure to control core temperature is associated with worse outcome. In a study, they have noted that each degree over 37 degrees Celsius during the first 48 hours of cardiac arrest is associated with worse neurological outcome. And early onset fever is also associated with worse outcomes. If the fever develops after 48 hours, it does not affect the outcomes that much. Now, indications of the hypothermia. So patients who are not following commands or showing purposeful movements following resuscitation, pregnant women, hemodynamically unstable patients, patients who are undergoing thrombolysis or coronary catheterization, they all can undergo therapeutic hypothermia, and there is no contraindication as such. Only contraindication would be having an advance directive to not do any aggressive treatment or resuscitate in such scenario. And also if there is active non-compressible bleed, then we may not go up to 32 or 34 degree, and we may go for targeted temperature management of around 36 or little less than that. Timing is as early as possible. So when the circulation is achieved and patient is not responding, we should start it immediately. Active control of temperature for at least 48 hours should be maintained, but definitely for 24 hours, and we should start rewarming. So it will go up to 48 hours. In a trial of 355 patients, they noted that 48 versus 24 hours. So 48-hour patient had good functional outcome, but at the same time, 48-hour patients had longer ICU length of stay and more adverse effects. So 24 hours is the standard duration advised in the American Heart Association and Circulation. With the goal temperature. So this is a trial 33 degree versus 36 degree published in NEJM in 2013. And they found that unconscious survivors of out-of-hospital cardiac arrest targeted a temperature of 36 versus 36 did not show any benefit with 33. So both the temperatures were equal in terms of neurological outcome. And from Indian point of view, probably achieving 36 is easier than a lower temperature. This is another trial published in 2019 for non-shockable cardiac arrest from non-shockable rhythms. Around 500 patients were taken. And here also they gave therapeutic hypothermia at 33 versus no temperature monitoring. And they found that definitely it is beneficial. This is from up to date. They are suggesting to use 36 degree for 24 hours in uncomplicated patients who have moderate coma, some motor response or no malignant EEG patterns, and no evidence of cerebral edema on CT scan. And they are advising lower temperatures of 33 degree for at least 24 hours when deep coma, like loss of motor response or brainstem reflexes, malignant EEG patterns like epileptiform discharges, or early CT changes suggesting development of cerebral edema. What are the methods for implementing hypothermia. So intravascular include rapid infusion of cold crystalloids, 4 degrees Celsius. Generally, we begin with 30 ml per kg of normal saline or Ringer's lactate. There are IV cooling devices also. We have not been able to use them. We don't have access to these devices, but literature describes them also. Along with that, surface methods, ice packs at the neck, axilla, and groin, where all the large vessels are, the blood is flowing. Cooling vest or blankets, cold water immersion. We have to at the same time note that if the patient is in heart failure or having pulmonary edema, or patient is is oliguric or acute kidney shutdown, in these cases we cannot give such large volumes. So probably we should restrict the volume and at the same time employ surface methods along with the IV cooling. There is no evidence as such of superiority of any method over the other. While giving therapeutic hypothermia, we should monitor the core temperature, the gold standard being central venous temperature. In our practice, we are doing rectal probes. In order of preference, esophageal, bladder, and rectal probes. Core temperature is a close approximation of brain temperature. We have to note that the rectal temperature lags behind little bit. So whatever the core temperature is, the rectal temperature would lag behind by 1 hour or so. So that we should be aware of. Shivering raises body temperature and must be suppressed in patients being treated with TH or temperature management. Failure to suppress shivering is the commonest reason for delay in achieving goal temperature. We can use sedatives like propofol infusion and fentanyl infusion with intermittent midazolam may be added if the shivering is not controlled. Midazolam is not preferred because generally these patients are hypotensive and generally they have liver or kidney injury at the same time. So midazolam accumulates in the body and may take days to for the patient to wake up. Dexmedetomidine is another option, but it is also associated with hypotension and bradycardia, and it is also not the frontline drug to be used. Neuromuscular blockade is highly effective at suppressing shivering, but it can mask seizures. So seizures develop in around up to 3 to 44% of patients. So continuous EEG monitoring is needed for the safe use of neuromuscular blockade. Now, once 24 hours are over, we have to rewarm the patient. The rate of rewarming should be conservative, around 0.2 to 0.25 degrees Celsius per hour, and should not exceed 0.5 degrees Celsius per hour. Rapid rewarming can cause electrolyte abnormalities like hyperkalemia, cerebral edema, seizures, and other problems. And in animal models, they have found that the effects of therapeutic hypothermia are actually reversed, eliminated following rapid rewarming. So rewarming should also be slow. Now coming to the potential adverse effects of therapeutic hypothermia. So coagulopathy is one important adverse effect. Hypothermia will lead to decrease in the platelet function as well as slowing of the clotting enzymes. Generally, these problems are more with the lower temperature. So temperature around 35, 36 degree would not have this problem. Low temperature also would decrease the leukocyte function and make patients susceptible to infection, pneumonia being the most common infection. Bradycardia and QTC prolongation can be seen on the ECG. Low temperature can also induce diuresis, which will lead to hypovolemia, loss of potassium and magnesium and phosphate. And low temperature can also lead to insulin resistance and need for higher dose of insulin. Along with the hypothermia, we have to obviously give general critical care as well. Propped up position, 30 to 45 degree, stress ulcer prophylaxis, DVT prophylaxis, glycemic control, nutrition and physiotherapy. Hyperglycemia is associated with worse clinical outcomes, so it has to be actively controlled. Now seizures and myoclonic jerks. They are common after cardiac arrest and they are markers of severe brain injury. EEG monitoring may be required to guide appropriate therapy and also provide prognostic information. There is no high quality evidence that clearly demonstrate benefit from prophylaxis for seizures. However, aggressive treatment should be given when epileptiform discharges progress to outright seizures, either convulsive or non-convulsive. The commonly used drugs are valproic acid, phenytoin, midazolam, and propofol. It is unclear whether treatment of epileptiform discharges that are not progressing into clear seizures is beneficial. So repetitive spike or sharp waves, typically generalized epileptiform discharges, can occur in up to 45% of patients. So here, Frontiers of Neurology in 2014, they have told that unstandardized treatment of EEG status epilepticus does not improve outcome in comatose patients. So it is not conclusive whether we can give treatment just based on that. Myoclonic jerks are also common after cardiac arrest. They can be isolated or epileptic. EEG is generally required to distinguish the etiology. No specific significance for isolated myoclonic jerks, but status myoclonus, which is repetitive jerks after lasting more than 30 minutes, is definitely an ominous sign. Coming to the prognosis. So what represents a poor neurological outcome? That is very important question. Cerebral performance score, that is CPC1, corresponds to best possible outcome or no or minor disabilities, while CPC5 corresponds to death. So this is the CPC, cerebral performance categories, and it is derived from the Glasgow outcome scale, which is also one of the grading system. And CPC1 being able to walk and lead a normal life, CPC2 being able to travel by public transport and work in a sheltered environment. But patient may have hemiplegia, seizures, ataxia, dysarthria, or memory changes. CPC3 being limited cognition and dementia, locked in or minimally conscious, usually in institution, but may be looked after at home with exceptional family effect. So CPC3, if we see in terms of quality, is not so good quality of life. There is no definite consensus on what represents a poor neurological outcome. These are the studies which have been performed starting from 1974 till 2014. And if you see in last 10 to 15 years, most studies included severe neurological disability among poor. So earlier studies used to have CPC 1 and 2 as good outcomes, while CPC as desirable outcomes. But now CPC and 3 as well. And now CPC 3 is considered as poor. So
Varun, you will need to close soon.
Yes, sir. Only 2-3 slides are there. So this is a summary from the International Liaison on Cardiac Arrest and Resuscitation, ILCOR. So once after cardiac arrest, we should go for controlled temperature management. After first 24 hours, we should go for rewarming. We should exclude the confounders, particularly residual sedation. And after 48 hours, we should assess the motor response. If motor response is 1 or 2, after 3 days of ROSC, we should, for prognostication purpose, we should see the pupillary and corneal reflex and bilateral N20 SACP waves. And if either of them is absent, the outcome is generally poor. If both of them are, if so, not absent, we go further, wait for at least 24 hours. And we should assess further whether there is myoclonus within the first 48 hours after ROSC, or whether there is high neuron specific enolase or unreactive burst suppression on status epilepticus on the EEG, or diffuse anoxic injury on CT, brain, or MRI. If two of them are present, more than two of them, then also poor outcome is likely. If none of them can be, so through them also, if we cannot come to a conclusion, generally there is indeterminate outcome, and we have to observe and re-evaluate. We have to use multimodal prognostication wherever possible. So these are the good prognostic outcome: presence of continuous or nearly continuous EEG within 12 hours, presence of early EEG reactivity, improvement of auditory discrimination from the first to the second day after ROSC, absence of DWI abnormalities on MRI within 1 week of ROSC. We have to have a shared decision making. So the patient's wishes have to be accounted for, the relatives have to be explained, and we have to tell them that there is uncertainty and we are also not sure about that. So certain uncertainties are there. They have to be told to the patient attendants. And such patients, when they recover, they have to be assessed before discharge, and most of them would have some neurological defect. So they have to be sent to rehabilitation to the specialized center. And they might also require cognitive therapy. So that is all from my side. Thank you.
Good. Thank you, Varun. Thank you very much, Varun. I think I like the way you say there are certain uncertainties. That is what medicine is about, no? You are certain of the uncertainties. Yeah. Varun, I want to know, you showed the figure of how many people get cardiac arrest.
Yes, sir.
How many get sequelae?
Sir, I could not get that data, how many get sequelae. But that depends on the duration of the arrest and how the CPR
No, all
was
that's
given.
okay. At the end of all that, how many are left behind with problems?
Sir, I don't have the number.
What percentage roughly?
I don't have the numbers.
It's a sizable percentage that we all appreciate. So I think it's also important to appreciate that in trying to do good, you also create something not so good. That's the whole problem of these certain uncertainties.
Yes, sir.
No, I mean, you want to treat the cardiac arrest, but you create an individual oftentimes who's no good for himself.
Yes, sir.
So
at the time of giving CPR, if we think like that, probably we would end up in a half-hearted attempt. That would be rather more having more sequelae than.
yeah. See, I mean, the seniors will appreciate this. That trying to do good is a very broad general concept. It has all these little tags attached to it, which when you see them, when you see the same good from another angle, it doesn't look that good.
Right,
Sorry
sir.
sorry for the digression. Yeah. So let's come to the last one. So Dr. Katrak, sir, you want to make any comment before we go to the last one? No, I think so. Let's go to the last one.
So good morning, everyone. Am I audible, sir?
Yes, very much so.
Yes. So good morning, everybody. The final presentation for the continuum. The topic is critical care of neuromuscular disorders.
Oh, good.
So this is the outline, a basic introduction.
Terrible. Yeah.
At least
I'll rush to. I'll rush
expert for this.
Yes.
Yeah. Sorry.
Yes, sir.
Do go ahead. Yeah.
Critical illness, myopathy and neuropathy, rhabdomyolysis, myasthenia, GBS, amyotrophic lateral sclerosis, organophosphorus intoxication, and snakebite envenomation if time permits. So coming to introduction, so the clinical evaluation of weakness in the ICU can be challenging. Often the patients are encephalopathic, sedated, mechanically ventilated, or uncooperative. So that's why we need a systematic approach to identify the etiology of the weakness. Of course, management of the patient's airway, breathing, and circulation should always take precedence over obtaining a detailed history and neurological examination. So this is a table in the continuum itself. The clinical findings associated with weakness in the ICU, some possible diagnosis with the clinical findings. So if a patient has acute tetraplegia with sparing of eye movements, locked-in dual neuromuscular blockade would be a differential. If a patient presents with descending paralysis, envenomation, especially snake bite envenomation and botulism would be the DDs. Ascending paralysis, GBS and tick paralysis would be the DDs. If a patient presents with gastrointestinal symptoms and we would think of heavy metal toxicity. And if a patient has abdominal pain, psychiatric symptoms, along with autonomic symptoms, acute intermittent porphyria comes first on the list. A heliotrope rash, then dermatomyositis would be the differential. And if a patient presents with episodic weakness with family history, periodic paralysis would be a differential. So what would be the anatomic localization of weakness in patients in the ICU? So if a patient has distal more than proximal weakness with extensor weakness more than flexors, with sensory loss present and increased reflexes, we would localize the lesion to the cerebral cortex, brainstem, or spinal cord. If a patient has proximal and distal weakness with no sensory loss, then anterior horn cell would be the localization. If there is a specific stocking and glove pattern of weakness with sensory loss and decreased reflexes, peripheral nerve would be the localization. Then if a patient presents with generalized weakness with fatigability, absent sensory loss, and normal reflexes, neuromuscular junction would be the localization. And if a patient has proximal weakness with absent sensory loss, with normal reflexes, we localize the lesion to the muscle. So these are the various differential diagnoses. We have motor neuron diseases like ALS, polio, West Nile virus, paraneoplastic motor neuron disease, and Kennedy disease. Peripheral nerve, of course, GBS, polyneuropathies, porphyria, vasculitis, and toxins. Then critical illness neuropathy, which is the most important. In muscle, we have critical illness myopathy, polymyositis, periodic paralysis, deficiency, and muscle dystrophy. And neuromuscular junction, myasthenia and Lambert-Eaton with botulism and snakebite are the most important. Hypermagnesemia and prolonged neuromuscular blockade are very, very important in this scenario, especially magnesium. So that's why in all patients in the ICU, we should definitely get a magnesium level because it is the most treatable condition. So respiratory failure in neuromuscular disorders, the risk of respiratory failure is high in acute neuromuscular disorders, especially when respiratory mechanics are affected. So the signs can be as such as restlessness. Other signs of impending respiratory failure include tachycardia, tachypnea, use of accessory respiratory muscles, staccato speech, paradoxical breathing, weak cough, and difficulty counting aloud from 1 to 20 in a single breath. So oxygen should be administered judiciously to keep saturation between 90 and 95% to avoid carbon dioxide retention. Although non-invasive ventilation could be a temporizing measure, it should not be used to avoid intubation if the patient is at a high risk of respiratory failure. A normal PCO2 in a patient with tachypnea may be a sign of impending fatigue and respiratory failure, and an elevated PCO2 may be too late of a finding. So we'll just briefly discuss some topics. We'll first come to critical illness, myopathies, and neuropathies. So new weakness in a patient who is critically ill is referred to as ICU-acquired weakness, which is defined as clinically detected weakness in critically ill patients in whom there is etiology other than critical illness. The risk factors include immobilization, sepsis, multi-organ failure, use of vasopressors or aminoglycosides, septic encephalopathy, hyperglycemia, steroids, hyperosmolality, hypoalbuminemia, and renal replacement therapy. The pathophysiology is multifactorial, ranging from bioenergetic failure to microvascular alterations, ultimately resulting in functional and structural alterations to the nerves, muscles, or both. They typically present with generalized weakness, more pronounced proximally, and failure to wean from mechanical ventilation. Facial, ocular, and bulbar muscles are usually spared. So the American Thoracic Society guidelines emphasize the importance of using the MRC scale as a standard to assess muscle weakness. 6 different bilateral muscle groups should be tested, which include wrist extension, elbow flexion, shoulder abduction, foot dorsiflexion, knee extension, and hip flexion. An MRC sum score of less than 48 is diagnostic of ICU-acquired weakness. Deep tendon reflexes are reduced or absent in severe weakness or neuropathic cases. Sensory, although present, is not as severe as the weakness. Nerve conduction studies usually show a reduction in the amplitude of the compound muscle action potential. A normal CMAP 8 days after ICU admission has a high predictive value of excluding ICU-acquired weakness. Then there's something known as a nerve to muscle CMAP ratio, which can help to differentiate between a muscle and a nerve injury. So what we do in this is the first CMAP is obtained by stimulating the nerve. The second CMAP is obtained by direct stimulation of the muscle following. So then a nerve to muscle CMAP ratio of less than 0.5 is diagnostic of an isolated neuropathy, and a ratio of more than 0.5 is diagnostic of either a myopathy or combined etiology. To further differentiate between a muscle and nerve etiology, measurement of the motor unit action potentials can be helpful. In myopathies, the MUAP duration is short and amplitude is low. So the therapeutic options include early mobilization, blood sugar control with intensive insulin therapy. Immunoglobulin infusion may theoretically have a therapeutic application, but a randomized clinical trial using either 0.25 gram per kilogram per day or 1% of human albumin solution over 3 days had no treatment effect on critical illness, myopathy, or neuropathy. So now we come to rhabdomyolysis. Rhabdomyolysis occurs with a wide spectrum of signs and symptoms, ranging muscle pain and varying degrees of generalized weakness. Markedly elevated plasma creatine kinase may lead to myoglobinuria and acute kidney injury. Creatine kinase levels tend to rise in the first 12 hours, peak on the second or third day, and return to baseline 3 to 5 days later. So although creatine kinase is considered the biochemical gold standard, serum myoglobin is considered the gold standard investigation, especially for the extent of acute kidney injury. So once a definitive diagnosis of rhabdomyolysis is established, fluid infusion should be immediately initiated. The goal is to maintain a urinary output of 200 ml per hour 200 to 300 ml per hour, sorry, and a urine pH of more than 6.5 with plasma pH of less than 7.5. Fluid should be tapered once myoglobinuria is clear, and the precipitating conditions must be promptly managed. Then this has been mentioned in the last few presentations called propofol infusion syndrome. So high doses of propofol, more than 5 milligram per kilogram per hour, given for a prolonged period of time, is a contributing factor. It can be fatal and is characterized by metabolic acidosis, cardiac and renal failure, rhabdomyolysis, myoglobinuria, and hyperlipidemia. So prompt recognition and interruption of propofol infusion can reverse the syndrome. Then G6PD deficiency is a rare cause of rhabdomyolysis. Breslin et al. Reported a case of a 30-year-old pentathlon-trained athlete with a previous history of exercise-induced pigmenturia who was diagnosed with a G6PD deficiency when he presented with unconsciousness, rhabdomyolysis, and hemolysis after running for about 12 kilometers. The same authors also published 3 other cases of males who were diagnosed with a G6PD deficiency during evaluation of recurrent unexplained myalgias, muscle fatigability, or exercise-induced myoglobinuria. So the thing is that severe rhabdomyolysis deficiency is not a common presentation because skeletal muscles are more resistant to oxidative damage compared to the RBCs. So that's why the reason I included this was because G6PD deficiency, although a rare cause, we should keep it in the differentials of rhabdomyolysis. Now, myasthenia gravis, we all know about it. It's an autoimmune disorder characterized by defective neuromuscular junction transmission due to antibodies directed against postsynaptic acetylcholine receptor with a bimodal age distribution, higher incidence in young women. So these are the types of myasthenia gravis: early onset at an age of less than 50, late onset more than 50, thymoma associated, muscle-specific tyrosine myasthenia gravis, and lipoprotein receptor-related for myasthenia gravis. So the clinical features, as we all know, is fatigable weakness, ptosis, ophthalmoparesis. Weakness in extraocular muscles is rarely symmetric. Limb weakness is symmetric with proximal preponderance. Gag reflex could be depressed, and head drop can be seen in patients with muscle-specific kinase antibodies. Now, myasthenic crisis is defined as myasthenia gravis complicated by respiratory failure, requiring mechanical ventilation or delayed extubation for more than 24 hours in an already intubated patient with myasthenia gravis. It is usually triggered by a precipitating factor, such as a preceding respiratory illness, surgery, and medications. So this is the most important. Some of the common medications implicated include aminoglycosides, quinolones, lithium, calcium channel blockers, chlorpromazine, cephalosporins, and penicillins. That is why it is very important to obtain a proper, we should always take a look at the drug charts of all patients in the ICU in a patient presenting with weakness. Although cholinergic crisis is rare, it certainly can result in an ICU admission and mimic myasthenic crisis. The presenting signs are consistent with cholinergic toxicity. The acronym SLUDGE, which it's an acronym for salivation, lacrimation, urination, defecation, GI upset, and emesis, is an excellent way to remember the symptoms of a cholinergic crisis. So the diagnosis of myasthenia gravis, all know it's the edrophonium test, IcePack test, repetitive nerve stimulation in which a CMAP decrement of at least 10% should be seen, single fiber EMG which shows jitter and blocking, antibody tests, acetylcholine receptor, MuSK antibody for bulbar myasthenia, and LRP4 antibody in seronegative cases. In 90% of patients with thymoma, anti-striational muscle antibodies can be seen. Patients with myasthenic crisis should be admitted in the neurocritical care unit if the airway appears at risk. Injecting drugs should be immediately stopped. Non-invasive ventilation should be started promptly. BiPAP support was found to decrease the need for intubation and decrease length of stay in the ICU. Elective intubation should be considered in patients with significant bulbar disease and respiratory weakness. Oral pyridostigmine is most commonly used. So that this is usually a symptomatic treatment and it can be stopped if the patient is intubated. Patients with positive MuSK antibodies have a poor response or intolerance to acetylcholine esterase inhibitors. And then the administration of either IVIG or plasma exchange is considered standard of care. Both therapies are effective, but combining the two therapies does not add any benefits. And then all patients with myasthenia in crisis should receive steroids. When they are first initiated, daily prednisone with 0.75 to 1 milligram per kilogram ideal is most commonly used. Airway watch should be considered in patients who are non-intubated, since 30 to 50% of patients may experience worsening of their myasthenia symptoms within days of starting steroid therapy. And the beneficial effect usually manifests after 2 to 6 weeks. Then azathioprine in combination with steroids is the suppressive therapy. And second-line agents include methotrexate, cyclophosphamide, mycophenolate mofetil, tacrolimus, and cyclosporin. Rituximab is another alternative as monotherapy and in refractory myasthenia gravis. It does appear to have more profound and long-lasting effect in patients with MuSK antibodies. Then a short word on Lambert-Eaton myasthenic syndrome. It is an autoimmune disorder of the neuromuscular junction with antibodies against the presynaptic voltage-gated calcium channels. It may occur as a paraneoplastic disorder in which small cell lung carcinoma is the most common cause, or a non-tumor related autoimmune disorder. Leg weakness is most often the first presenting symptoms, and then the weakness slowly progresses to involve the arms, distal muscles, and finally the cranial muscles. Generalized fatigue, dry mouth, impotence, dry eyes, constipation, and difficulty in swallowing are also reported. Cerebellar ataxia, although uncommon, is associated with paraneoplastic Lambert-Eaton myasthenic syndrome. Around 10% of patients with LEMS are seronegative for anti-VGCC antibodies. However, their absence does not exclude LEMS. Repetitive nerve stimulation should be done on at least 2 distal muscles. The test is considered positive if low amplitude CMAP is present at rest. Further decrease in CMAP of at least 10% occurs during low rate RNS, and an increase in CMAP by 100% occurs after a brief maximal contraction. So the potassium channel blocker 3,4-diaminopyridine is an effective symptomatic treatment. Patients with persistent symptoms may also need steroids, IVIG, or Plex, and in some cases azathioprine. And the neurocritical care unit needs are usually centered around respiratory failure or infectious complications. Now a brief word on Guillain-Barré syndrome. So it is an autoimmune mediated nerve injury characterized by acute, rapidly progressive, and symmetric ascending weakness. It is a syndrome of polyradicular neuropathies that includes AIDP, acute motor axonal neuropathy, acute motor sensory axonal neuropathy, and Miller-Fisher syndrome. A variety of infectious agents have been implicated, including cytomegalovirus, Epstein-Barr virus, herpes simplex, Campylobacter, even Zika virus. Immunization, recent surgery, and renal transplant have been associated with GBS. As I mentioned, it's characterized by ascending weakness and areflexia. Other features include dysesthesias of limbs, facial and oropharyngeal weakness. Ophthalmoparesis is seen in the Miller-Fisher variant. In the CSF, as we immunocytological dissociation. Early in the disease, the only electrophysiological abnormality is delayed or absent F waves on the nerve conduction study. So the following are the criteria used for admitting patients with GBS to the neurocritical care unit. Rapid progression of motor weakness, including respiratory muscles, presence of bulbar dysfunction and bilateral facial palsy, autonomic dysfunction, arrhythmia and bradycardia, and medical complications like DVT, pulmonary embolus, MI, or sepsis. So the pulmonary function tests measuring forced pressure, maximal expiratory pressure, and vital capacity are very useful in tracking disease progression. The 20-30-40 rule is often followed to decide on the need of intubation. Vital capacity, so that 20-30-40 rule is vital capacity decreased to 20 ml per kg, maximal inspiratory pressure decreased to minus 30 centimeter of water, and maximal expiratory pressure decreased to 40 centimeter of water. Then several clinical criteria should be met prior to extubation of a patient with GBS, which includes vital capacity of greater than 15 ml per kg, maximal inspiratory pressure better than minus 30 centimeter of water, and satisfactory oxygenation. Most patients with GBS need a tracheostomy since mechanical ventilation duration is prolonged in some cases. Absent motor responses and widespread fibrillations early in the course of the disease are predictive of prolonged intubation. Lack of foot flexion mission and at the end of therapy or inability to lift the arm 1 week after intubation are also highly predictive of ventilation. Dysautonomia is associated with a higher mortality in cases of severe GBS. Patients with labile blood pressure also need ICU monitoring, and patients with GBS admitted to the ICU are often hypercatabolic. So enteral feeding should be instituted as soon as possible to avoid an increased risk of infectious complications and failure to wean from mechanical ventilation. An initial replacement at 30 kilocalories per kg to 40 kilocalories per kg of non-protein calories and 2 gram per kg to 2 to 2.5 gram per kg of protein is recommended. Then we can use either IVIG or plasma exchange for GBS. So the side effects of IVIG: reversible encephalopathy, chest pain, infusion-related side effects, thromboembolism, aseptic meningitis, AKI, and allergic reactions. So that's why we should always do an IgA level before instituting IVIG therapy. And the side effects of plasma exchange include paresthesias, mainly due to hypocalcemia, transfusion reactions, hypotension, pneumothorax, and hematoma.
So
Plasma exchanges.
ICU, which one would you prefer?
Sir, we would
talking about the ICU. This is all theoretical,
yes,
but from a practical point of view, you all should make a suggestion that which is more useful in the ICU setting. You are
yes,
talking about critical care of neuromuscular disorders.
yes. Yes.
So answer my question. Which one would you prefer?
Sir, plasma exchange because
Isn't that associated with hypotension, etc.?
yes,
Wouldn't it be easier to give IG?
yes, sir. IVIG would be more convenient and more comfortable also and easy to initiate. But yes, hello. So may I continue?
Yeah, please.
Yes. So, like I said, the advantage of plasma exchange is it allows for IVIG as a second course of treatment in patients who are refractory to treatment. So the factors associated with poor outcome in GBS include an older age, a rapid progression to severe weakness, which is 7 days or less, a need for ventilatory support, and a mean distal CMAP amplitude of 20% of normal or less. So patients who are mechanically ventilated continue to have a higher mortality rate ranging from 15 to 30%. Despite close monitoring in the ICU, acute mortality is mostly caused by dysautonomia, infection, acute respiratory distress syndrome, or pulmonary emboli. So now we'll discuss briefly about amyotrophic lateral sclerosis or motor neuron disease. It is a progressive disease characterized by upper and lower motor neuron signs. There is progressive weakness observed in bulbar, limb, thoracic, and abdominal muscles. Oculomotor and sphincter function are usually not affected. The types of ALS include limb onset ALS, which has both upper motor and lower motor neuron signs, bulbar onset ALS, which features dysphagia and dysarthria, and upper motor and lower motor neuron signs that occur after the disease progresses, primary lateral sclerosis, which has upper motor neuron involvement only, and progressive muscular atrophy, which has lower motor neuron involvement only. Frontotemporal dementia and frontal lobe cognitive impairment can occur in patients with ALS. Then isolated diaphragmatic weakness with progressive ventilatory failure is an uncommon variant of ALS in which the patients usually present with difficulty to wean off, and then that is when an isolated diaphragmatic weakness is diagnosed in such patients. So what is the approach to symptomatic management of ALS in the ICU? So for sialorrhea, we give amitriptyline. We can give amitriptyline or atropine, transdermal scopolamine, or even Botox injection to the parotid gland in patients refractory to treatment. For pseudobulbar emotional lability, Combination of dextromethorphan and quinidine with antidepressants such as amitriptyline, fluvoxamine, and citalopram may be used. For cramps, levetiracetam 500 milligrams twice a day for 7 days, then 1000 milligrams twice daily for 7 days, and 1500 milligrams twice daily has been used in patients of ALS presenting with cramps in the ICU. For spasticity, regular physiotherapy is important, and antispasticity drugs may be tried. Respiratory complications are the main cause of death in patients with ALS due to diaphragmatic weakness, aspiration, or pneumonia. Supine forced vital capacity, sniff nasal pressure showed greater predictive power than forced vital capacity in predicting the respiratory complications in patients of ALS ICU. Patients with ALS without severe bulbar dysfunction treated with non-invasive pressure ventilation had an improved quality of life and survived longer. Ventilation via tracheostomy should be offered as an alternative to patients who do not tolerate non-invasive positive pressure ventilation. So in the ICU, in patients of ALS, ineffective coughing often leads to retained secretions and ultimately to pneumonia. So a peak cough expiratory flow of more than 160 is needed to clear secretions. Assistive devices are recommended once peak cough expiratory flow drops below 270 liters per minute. N-acetylcysteine, beta receptor antagonists, or anticholinergic bronchodilators should be tried to decrease bronchial secretions. Oral intake is usually limited in patients with dysphagia. A BMI of less than 18.5 kilogram per square meter is associated with a shorter survival, and moderate obesity, that is a BMI of 30 to 35, is associated with slower disease progression and longer survival. Then a percutaneous endoscopic gastrostomy tube is recommended in patients with ALS with poor oral intake to improve survival and stabilize weight loss. So this is a PROGAS study done to compare the effects of percutaneous endoscopic gastrostomy versus radiologically inserted gastrostomy versus perioral guided gastrostomy. So the desaturation was almost similar in all groups, but it was less in radiologically inserted gastrostomy. The patient distress was the least in radiologically inserted gastrostomy and most in percutaneous endoscopic gastrostomy. Respiratory arrest was not seen in either of the patients. Most of the patients who had perioral guided gastrostomy experienced the most pain, and the risk of pneumonia was highest in perioral image guided gastrostomy. That's why percutaneous endoscopic gastrostomy is the most commonly used in the ICU. Then this is a graph which shows that in patients up to 10% of the weight, up to 10% of weight loss, what is the outcome of inserting a PEG tube? So those who have more than 10% weight loss, the outcome is not very good. So that's why it's better to go ahead with PEG tube insertion in MND patients before they have a low BMI.
You need to conclude, Swati.
Yes, sir. So I'll just cover, this is the last topic, organophosphate intoxication. So organophosphorus irreversibly inhibits acetylcholinesterase, resulting in excessive amounts of acetylcholine at the neuromuscular junction and prolonged end plate potential and desensitization of the postsynaptic membrane. So this desensitization is responsible for the decremental response occurring with OP with organophosphorus intoxication. We can see muscarinic and nicotinic symptoms, which include pupillary constriction, increased bronchial secretion, sweating, and bradycardia. And the nicotinic effects reflect inhibition of the acetylcholinesterase enzyme at the neuromuscular junction. Fasciculations are initially observed in the eyelids, which progress to the face and calves and then become generalized. Respiratory muscles are especially affected, resulting in respiratory failure. And severe intoxication can progress to coma and tonic-clonic seizures. So patients are admitted to the ICU for monitoring of vital capacity and neurological examination. Frequent washing of contaminated skin is important. Anticonvulsants are advised despite the low risk of seizures. And in the case of excessive secretions, atropine is recommended. Patients should be treated with pralidoxime within a few hours to avoid phosphorylated acetylcholine resistant to reactivation. So since we're short of time, I will not cover the snakebite envenomation. I'll just go to conclusion. So management of neuromuscular disorders in neurocritical care unit centers around prompt it requires prompt identification and management of respiratory failure. And ICU management has contributed to improve mortality in the last decade. As the spectrum has changed, with most neuromuscular disorders in the ICU being related to ICU-acquired weakness, it is essential that we attempt to better understand the pathophysiology of these disorders and develop new therapeutic approaches. Thank you.
Great. Thank you, Swati. Chinmay? Chinmay,
Any
are you
comment
there?
from you?
Yeah. No, I wanted to ask Chinmay before commenting, do we have to close at 12 or are there a few minutes more?
Can exceed a little bit.
Yeah, okay. Actually, there are 2-3 comments that I sort of wrote down as the lecture went on. I think the most important thing is when you see somebody with a neuromuscular weakness in the ICU, you have to first sort out, is it a pre-existent disease that has come in the ICU? Is it a new disease that has manifested now? Or is this condition come out of what has happened in the ICU? So I think there are primarily 3 categories in the neuromuscular disorders that you will see in the ICU. Say, for example, a myotonic muscular dystrophy patient who progressively becomes weak and then comes into the ICU with a pneumonia. As first example. Second example is a newly diagnosed rhabdomyolysis, which has happened in 2-3 days, and I just brought to the person straight to the ICU.
Can I
And
interrupt here 1 minute?
Yes, sir.
You gave the example of myotonic dystrophy.
Yes.
These patients are also prone to cardiac arrhythmias and cardiac arrest.
Absolutely.
And they may come into the ICU because of a cardiac.
Because of various reasons. Yeah, absolutely. Yeah. And the third is the critical care neuromyopathy, which occurs because of the ICU stay. So you have to primarily categorize them, the diseases that you're seeing, in one of these 3 categories. And then it will be easier for you to then further get down to the diagnosis. That's the first comment. The second is, I think I want to give you an example of the ICU related neuromyopathy as to how literature develops. When firstly people started seeing ill patients who became weak, they thought it was a neuropathy. So the condition of the ICU associated neuropathy or a critical illness neuropathy came into existence. As they studied the condition more, they realized that some of them or a lot of them also have a myopathic component. So critical illness myopathy came into being. Then there are definitions of pure critical illness neuropathy, definitions of pure critical illness myopathy. But the truth is that in most people, it is a neuromyopathy. So all these true things, as they evolve, have now merged into the neuromyopathy. Now they have classified myopathy into 5 types: the tubular accumulation and mitochondrial dysfunction and what have you. So that's how the whole thing goes on, increasing and getting itself complicated. But I think the basics are that if somebody is very seriously ill, requiring a ventilator, has infection, and in whom steroids are used, nerves and muscles will become weak. Their mechanisms may be variable. Once that happens, you are in trouble because a lot of time will go before such an individual actually comes back to a useful existence. The third comment is about cholinergic crises.
The that Karthik had shown is very true for critical care neuromyopathy.
Yes.
You have to unlearn and then relearn.
Absolutely. Absolutely. The comment about the cholinergic crisis is that it's really exceptionally rare to see cholinergic crisis. I don't know collectively how many of us have seen overestimated. I mean, it's always there. You say first stop the drugs because it could be cholinergic crisis, but that's very, very rare in practical terms. So when you see a patient of myasthenia who has become bad, it is myasthenic crisis unless proven otherwise. This cholinergic business, okay, it's there for the records. And lastly, I think you put on one slide of ALS the comment on amitriptyline being used in an ALS patient for sialorrhea
Yes, sir.
in the dose of 10 milligram 3 times a day. I think that somehow doesn't,
The whole day.
I'm not happy about it. One, 3 times a day, not happy about the dosage. Secondly, giving a person whose ventilation may be compromised
Correct.
for excessive salivation doesn't make. So I think, did it come to your mind when you read this slide that this is not making sense? I've never seen my teachers giving this.
Yes, sir. That table was there in the continuum, so
Well,
I
it's
just.
there. It's there. It's your
No,
job
sir, I
to
never.
put
Yes,
it
sir.
in perspective now.
Yes,
Swati,
sir.
please remember, okay, this
Yes,
table is meant for American audiences.
yes, sir.
Yeah.
And I think we Indians don't tolerate
Yes.
amitriptyline even once a day.
Yes.
10
True.
milligram once a day.
Correct.
Yes.
Also for sialorrhea, I don't remember having used it at all. There is atropine,
Yes.
gurgles, glycopyrrolate. There are other options available. No?
Yes, sir. Yes, absolutely.
One question. They have
Yes.
recommended various strategies to reduce the incidence of critical illness neuromyopathy. So I use that word because for any better word, like control of sugar, give physiotherapy, what have you. But in a person with prolonged ICU stay, does anything like this work?
No.
I never felt it worked.
No. If it has to happen, it will happen.
Yeah.
This is what you do to
Yes.
feel comfortable with yourself.
Yes.
If it has to happen, it will happen.
Correct.
I think that's better. I go with that. Whatever I tried, nothing has worked.
No.
No.
It's just time and natural evolution, gradual improvement.
I would like to make a few comments.
Yes, sir.
Basically. Today, all the people, they gave a very exhaustive review. However, I think they should be a little selective about their slides, because it is also important that you remain within your time constraints and time your slides according to that.
Yeah.
Okay. The second comment that I'd like to make is, okay, please try and read in between the lines of continuum.
You always said this, sir.
And
Every year you tell this.
And
Yeah.
give a little bit of Indian perspective to the whole talk.
Correct.
Particularly in the epidemiology. We always quote American data and this and that and whatnot. But I think the person who takes up the topic must look at a little bit of Indian data and give it to us. And I think this continuum gives a very nice take-home messages in the columns, key points.
Yeah.
Yeah, they're brilliant.
Pay attention to those key points and then formulate your slides. You will give us really the core of the content.
True.
So don't try and cover this whole topic exhaustively. I would like you all to use your sort of discriminative sense.
Yeah. Sir, I made a format. I'll show it afterwards. Then we can approve it and send it to people for making their presentations.
And the last thing I said, we have five consultants on the panel here. For next time, I think one consultant will be kept in charge of one topic.
Perfect.
You allow, and the candidate will have to send his or her slides to the consultant for approval.
Correct. Yeah.
And then the consultant may not only give his opinion, but he may also give, say, a little extra reading of what he has done in a nutshell if it is not covered by the chapter.
Yes.
I think that would strengthen the whole continuum
Correct.
much better.
Yeah.
Okay.
So, Azad, before we close the room, do you want to tell about next year's schedule to them? And then we'll request Dr. Karthik to give them some message for end of the year before we close the room, and then 5 minutes we'll discuss the format amongst ourselves.
I think the next one is going to be on 31st of Jan.
Yeah.
Which is the last Sunday of January. And the topic is going to be dementia.
Yes.
Now, I have selected 5 topics. I'll read out all the topics. They have late onset Alzheimer's, which a lot has been read, lot has been said about it. But I think I would select the topic of early onset Alzheimer's disease variants.
Yeah. Correct.
That is one.
It's a beautifully written chapter. Yeah.
The second topic that I would like to select is posterior cortical atrophy, a often neglected entity.
Yes.
Which we sometimes see on the MRI and don't correlate with the patient's dementia.
Yes.
Then there is behavioral variant FTD and primary progressive aphasia and apraxia of speech. Again, FTD. I think both those chapters should be combined. Okay. Then there's Lewy body dementia and vascular cognitive impairment. I think which is well studied in the cerebrovascular part. Normal pressure hydrocephalus also I would not include. Chronic traumatic encephalopathy also I would not include. I would not include hippocampal sclerosis, argylophilic brain disease, and primary age-related tauopathies. I think they are still in a fluctuating,
Right.
And I would include the last chapter, which is reversible dementia.
Absolutely.
Yeah.
Yeah.
So we have 5 topics.
Yes.
Early onset Alzheimer's disease and variants, posterior cortical atrophy. Somebody good must take on behavioral variant and primary progressive aphasia. I think difficult to cover within 20 minutes. So if you are given 25 minutes for that, or even half an hour.
30.
Okay. Then Lewy body dementia. And lastly is reversible dementia.
Perfect.
If you personally ask me, I would like to supervise early onset Alzheimer's disease and its variants.
I'll take reversible dementia.
Okay. Jimmy?
Whatever you say.
Jimmy, you take Lewy body because
Okay.
the Parkinsonian thing comes up. Yeah.
Okay.
Yeah.
And Ashok, behavioral variant and primary progressive aphasia.
Yeah.
So that leaves only posterior cortical atrophy. Can we give that to Rahul?
Yeah. Rahul has been on the panel, but he's not shown
not
up.
present.
So we'll talk to him.
Okay.
We'll talk to him. Yeah.
And Azad,
Yes, sir.
So Azad, I think the participants will leave the thing to you.
Yeah.
Sure.
That will, between him and me, we can work out.
Yeah, you and Azad both
Yeah.
are participants
Yeah.
and inform each contestant about it.
Yes.
Okay.
Yeah. So do you want to give them a message before we close the room? Year is ending.
Yeah.
And the new season starts next year.
I mean, usually we were 1 year late.
Yeah.
Now I think we've become 2 years late for this. Because this dementia chapter is for 2019 February issue.
Yeah.
Anyway, we'll catch up within 3 months. I would like to time it as the last Sunday of the month. So
correct.
31st, it will be 28th of February. And I think we'll have to look up March.
Yeah.
All right. And the topics are actually dementia, epilepsy, and sorry, just one second. Dementia, epilepsy, and multiple sclerosis and other inflammatory disorders.
Fantastic.
The next three issues, Satish, you will have to pursue.
Yes.
With Helen Gallagher.
Yeah, I'll request them for online. We'll make it easy. Yeah.
But if they have shipped it, they have shipped it to various other people. So if they have shipped it, please get the
Okay.
Because we are a little easier with the Xeroxing and all that
Print
thing.
version. Yeah.
Okay.
Yeah.
And Azad?
Yes, sir.
Has Pratik Pawar given you the dementia Xeroxing?
No, sir. We've not had the Xerox copies yet.
Pratik is also on board. Pratik is also here.
We'll have to request Mr. Rahul Shah or Pratik.
Yeah.
Okay?
Yes, sir. Yes, sir. I am here. Sir.
Okay.
Yes, sir. We'll do it.
Yes, sir.
Fine.
Can we stop live streaming, sir?
No,
I think he has to give a message to them, then we stop.
Okay, sir. Okay. Yeah. Okay. Sir. You just let me know, sir, when to stop. Yeah.
Yes.
We'll talk. Now, the message is that this continuum has been going on uninterrupted since 2005. When I took over as the national coordinator. And at present, we have about 9 centers, all India. And based on the evaluation forms that are submitted to the World Federation of Neurology, I'm very proud to say that India has been #1 user since 2006.
Excellent.
And I think, I'm not very certain, but I think that this activity of mine was partially responsible for the fact that I got the Ted Munsart Award last year in 2019. Because it was Ted Munsart who was the founding editor of Continuum.
Okay.
And he started this whole Continuum thing, and he wanted the World Federation to also take part in it. So I think the award has been appropriately named after him, Neurology Education through the World Federation of Neurology. And I'm quite proud of it. I received that award, basically. Therefore, this is just a hint to the people who are going to follow in my footsteps. So that they also get a new award and just. I hope to continue. This is a good teaching program.
Yeah.
But basically, the students must understand that it has its limitations also. That many of the chapters in this booklet are directed towards physicians, neurologists in the US and have no relevance to us. Those chapters are usually not covered. Now at present, because of this virtual thing, we are bound down by time constraints, basically. But I think hopefully when everything starts developing, we hope to continue this thing again. All right. And I wish all of you a very happy New Year. More than happy, I hope it is healthy for all of us so that we can usually get together and rile each other on the face rather than through virtual media. Thank you very much.
Lovely. Thank you very much, sir, for being
Can I
there.
just half a minute, just want
Please.
to say that, I have been with this continuum for I don't know how many years now, and I truly, truly enjoyed not only the content, but to meet up with Dr. Katrak and Satish on Sundays and Ashok. It's been an absolute delight and pleasure, and I hope that this continues. I am missing the tea and the snacks which we could get at Jaslo. That's the only thing missing in the online thing.
You can get it yourself, Jimmy.
No, but if someone gives it, it's better. So thank you very, very much, and hope that
instead of tea and snacks, you can keep having your beer.
Yeah, this is the time for that now, 12 o'clock.
So I think, Rahul, we can close the room. And
Yes,
if you
sir.
can give me the sharing rights.
Yes, sir. Yes, sir. Rohit, please stop streaming, live streaming.
Done, sir.
Okay. Okay.
So basically, I think
Michael sir, you are mute. Michael sir, you are mute.
Basically, I think we had 53 participants today, which is, I think, quite good. Besides the faculty members, and we'll get the list and know who from where all they were.
Yes, sir.
And then we'll think of how to do it in a more wider manner. But just now, if with the screen sharing, if I can show you some thoughts about how to do these topics in the coming year.
Yes, sir.
So I'm sharing my screen.
Yes, sir.
Basically, like Dr. Katrak has always said, the people are reading the whole topic and then putting so much material on it that it becomes irrelevant. So I thought we
are just vomiting it out.
Yeah. So we could actually give them instructions to the speaker. And this is what I've lined out. Please read and assimilate the topic from the continuum and also use other relevant material. The purpose is to focus on contemporary concepts and recent happenings. Prepare up to 10 points that you think are most important and present them using 10 slides. 1 point per slide. Read Indian data on the subject and place it in 2 to 3 slides in appropriate places. They may come in between or they may come towards the end. Then whatever study material they've accumulated that's not to be presented can be sent to Azad and me, and we'll put it on the WhatsApp group so they can refer to it as and when they want. So this will break what they've read into what they're presenting and what they have sort of prepared. And then I was thinking that if we, whenever feasible, if we request a local expert, in addition to the consultants who are part of the continuum, like has been done before, to speak for a few minutes on what he or she thinks is most relevant. And we will keep 5 minutes for that person depending on the topic and depending on the local expertise available.
No, sorry.
So the format really will be 10 slides, then 3 slides, and then the local expert, then the discussion. And this I added just now, 1 consultant to be allotted to 1 student as per Dr. Katrak's suggestion, and then 20 minutes. So that means they have to actually send their presentations beforehand and get them curated before they actually bring it on. That will increase the quality.
Help them to do that also.
Yes.
Fine.
Now, so this I will circulate on the group. Any suggestions on this?
Yes, sir. I agree with this. In fact, from every zone or so, from where the students come, or from their own faculty, we could have 1 senior consultant to also help address the presentation.
I think, Dr. D'Souza, what we'll do, you give us a week or 2 before we discuss that.
Okay, sir.
We will sort of think about how to do it and we'll come back to you on that.
Fine, sir. Fine, sir. Fine.
But the idea is to go broader. But how to do it, we'll put our thoughts and get back to you.
That's fine. That's fine. That's fine. Excellent. Yes, sir.
Jimmy, Ashok, any suggestions on these?
No, I just have. Is that the next topic? How to catch up with backlog?
These instructions I'll send. And
Yeah,
then
I
I've got
think
these
that's
two other thoughts,
No, I
how
think
to
what
catch up
John
with the
also said
backlog.
just now about having one consultant per lecture is very well taken, and I think it will sort of streamline, because I think we are all on the same page, and
Correct.
we can guide. They'll give us the slides, and we can like some of these slides today were such busy slides where the whole it's not possible to read
that supervision is necessary.
Supervision would be very good.
Yes, very good.
Now, how to catch up with the backlog is one of the question. Can we drop one? Can we request the WFN to drop 1 year and come straight to the year that is coming?
That was exactly what I was just thinking. That would it be possible to maybe maybe one or two very useful sort of issues we can keep, but otherwise if we can sort of fast track onto the recent topics, it might be more
this has to go to them. No, they have to approve it.
Oh, I see.
Because they are supposedly they are sending, and then we are using.
No, we are getting the issues only 1 year later.
Correct, which is I think if we can request them to sort of do something about it, maybe we'll think about this. And electronic versions, I mean, can we how difficult is it for Intas to make electronic versions of the instead of Xeroxes? I mean, those we can give both options. Those who want Xeroxes can get Xeroxes.
We can do that, sir. We can do that. We can have that in a PDF file, and we can record this session, and we can give you the videos also, sir.
No, not this one. That's a separate thing. That just now you keep. We'll see how to use it. But the electronic version of the Continuum itself.
But sir, we need that content from them. So how, in which format you require? Like we can make a PDF or any sort of reading format.
That's right, reading format.
Yeah, we can, sir.
See, in place of Xeroxes that you make,
yes, sir.
Some people now may not mind keeping a PDF file.
Yes.
So we should probably make this from the PDF file only, no? Originally, how do you make it?
Done. We will do that. So we have a technology that we convert all physical copies into PDF.
Yeah.
And then we can give it.
So, like personally, I now find PDFs much easier to keep and store. But Dr. Katrak will enjoy the physical copy. So we'll have to have both options.
Yes, sir. Yes.
I think we should also ask the participants whether they are comfortable with the PDF or are they comfortable with a physical copy.
And whatever they require. Yeah.
Azad, when we get them, I think you please ask all the 57 participants. Are you comfortable with a PDF in the future, or are you comfortable with a physical copy?
Sure, sir.
I think before we take a decision, we better find what the majority
what they want. I think both available. What PDF, any number of copies can be provided. So what only has to be decided is how many need the physical copy. Only those many copies to be made.
We can after these 3 ones, we can remove the other 3 topics of this year, 2019. And request them to go directly for 2020.
Yes.
Correct.
Yes.
Correct.
So one thing we can do is that we can help in subscribing for the Continuum series per se. So directly you will get both the hard copy or the soft copy. That we can take the subscription for that.
Okay.
And you will get the subscription. So directly you will get the latest plus the back copies also. That is, it can also help in that way, sir.
See, if you do the subscription and get it on a PDF,
okay,
or you can get a hard copy.
Yes, that we look into that, sir, and we can give you both. I think it
allows both. Then we become current.
Yes, correct. Yes, that's what I was trying to suggest.
We become 2021, we will become 2021.
Yeah.
Yes, correct.
Actually, sir, a lot of us subscribe to it. A lot of us get these copies. So it's acquiring is not an issue. It will be nice if Intas acquires it for the group as an activity. But will the WFN allow us to do the same year? Should we inform them? Because I think it's important that we go same year.
I will have to write to Steve.
Let us write and sort of try and get there.
Also
this
to
thing.
Bill Carroll.
Yeah.
Okay, now one of the pharmaceutical companies is willing to subscribe to Continuum.
And can we do the current year?
With the current issues.
Correct. That will enhance the importance of it.
Follow all the other things.
Correct.
Getting the WFN, evaluation forms, posting the evaluation forms to them.
Yes, it's only we are doing current year.
I have a feeling they'll be more than happy to do it because they don't have to undergo the expense of posting.
Of sending them. Correct.
Right.
So let's put it to them and move it through. And if it comes through, then we request. Intas is quite comfortable, as I understand. Yeah.
Yes, sir.
Yeah.
Satish, then let's
formulate the mail and go.
Yeah, let us coordinate and then let's see about it. Please send me a report of the participants, etc.
Yes.
So I can write to Steve Lewis and I can write to Bill Carroll.
I'll send you the draft, sir.
Yeah.
I'll send you the draft. Yeah. So that was it. So I can stop sharing. And any other matters or we close?
I think we meet on 31st now.
Yeah.
But before
now
that,
we meet on the
preparation.
Yes. And I think we'll prepare well this, so we'll see how it goes. Yeah.
Yes.
It will be enjoyable. Great. Then we close at that.
Fine.
Thank you, sir.
Okay.
Jimmy, Ashok, anything? Yeah.
No. It's wonderful to have all of you. See you on 31st Jan.
See you.
We can see you before that also.
Yeah.
Okay.
That will be wonderful.
Bye.
Okay. Bye.
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 Thank you.
Bye.
Thank you. Good day.
Thank you, sir.
Thank you.
ठीक है सर, चलो बाय बाय सर। मैं कल सर हाँ देख लेते हैं फिर सर। हाँ
मेल आईडी दिए हैं।
हाँ क्या बोल रहे हैं?
मेल आईडी दिया है चिन्मय जी को।
हाँ ठीक है कोई प्रॉब्लम नहीं। तू भी ले लेना, वो तो हम दे देंगे।